Hello everyone. My name is Bilal Daboul. I'm a third-year medical student, and I'll be giving you the brainstem today. Now, this topic may seem daunting at first because it contains a lot of stuff. You have cross sections, you have cranial nerves, you have cranial nerve nuclei. However, my advice would be to generally try to understand the anatomy, understand the basic anatomy very well, and build on it in the lesion section. Because if you understand the tracts and the decussations, the crossing points, the transitions between the levels of the brainstem, then the lesion inshallah will be very simple to approach. If you have any questions, feel free to contact me through my email or even WhatsApp. Good luck on your exam in advance. I'll start with the first slide. Okay, so for starters, what is the brainstem? So the brainstem is a stalk-like structure, meaning it's a tube-like structure that connects the forebrain, so think upper parts of the brain like the cerebral cortex, the thalamus, and whatnot, to the spinal cord. So if you look at the image I put here, this whole thing is the brainstem. It connects the forebrain, so the upper portions of the brain, to the narrowest spinal cord. Now we have three major divisions for the brainstem. Okay, most superiorly you have the midbrain, then you have the pons and the medulla. Okay. As the name implies, the midbrain connects the lower portions of the brainstem to the upper portions of the brain. The pons is Latin for bridge, okay? Because if you look at a gross specimen, the pons would be spanning the two cerebellar hemispheres. So it looks like a bridge that connects the two. So this is the cerebellum, which is located posteriorly. You have the fourth ventricle here, which lies posterior to the medulla and the pons. And grossly, when you look at the brainstem from the front, it would look to be connecting the two cerebellar hemispheres. And finally, you have the medulla, which again connects the brainstem to the spinal cord. Now, in terms of functions, the brainstem functions as a conduit or channel for sensory and motor tracts. So ascending tracts and descending tracts. Some major ascending tracts you need to know about include the spinothalamic tract, which carries pain and temperature. This also includes the dorsal column, medial and meniscal tract or pathway. The major motor tract you need to be aware about is the corticospinal tract. This was covered in spinal cord. I'll be discussing it multiple times as we progress through the PAL, but it's important because the brainstem functions as a highway for these tracts, be it motor or sensory. The second function is that it contains the cranial nerve nuclei, specifically 3 through 12, so the oculomotor to the hypoglossal. Now, the first two cranial nerves are, related to the cerebrum, so upper parts of the brain. So don't really, worry about them too much. Again, it supplies the head and neck region. We'll get into the details. In terms of the ventricular system, the fourth ventricle, we have the cerebral aqueduct, which connects the third ventricle at the level of the thalami to the fourth ventricle. That's it for the introduction. Now, this is a very important slide. I see a lot of people getting confused about the two terms, rostral and caudal. Okay, when it comes to the brainstem, it's very simple. Rostral equals superior or upper sections. So if you notice, that's the midbrain, that's the pons, and that's the medulla. The rostral midbrain would be an upper section of the midbrain. Okay, the caudal midbrain would be a lower section of the midbrain. So we can say essentially that, for example, the pons is rostral to the medulla, okay, meaning it's superior to the medulla. We can say that the midbrain is rostral to the pons, the same thing. This is the rostral pole again, and that's the caudal pole or the inferior pole. Again, cauda means tail, simply translates to tail in Latin, so towards the inferior aspect of the body. Now, if you look here, that's you have two cross sections across the brainstem, specifically the medulla. So you see how we have a great difference in structures between the upper and lower sections of the medulla, so the rostral and caudal medulla. This is very important. This is always used in neuroanatomy, rostral and caudal. You need to get this because it will help you progress through the slides and the content. Now, when it comes to the brainstem, we are talking about external features. Okay, so you have some important anatomical landmarks that correspond to critical structures within the brainstem. So this is a ventral view. You're looking at the brainstem from the front. Okay. So I'll start with the medulla. This is the medulla for starters. You have the pons, which is the largest section of the brainstem, and then you have the midbrain. Okay. Now, if you look inferiorly, we have two bulbous protrusions, okay? They're referred to as the pyramids, the medullary pyramids. And they're essentially composed of corticospinal fibers, the corticospinal tract, which is a motor tract that descends. It originates from the motor cortex and descends through the brain, through the midbrain, the pons, and the medulla, okay, to get to the spinal cord and supply the lower motor neurons. At the level of the medulla, the fibers would regroup, they would condense, and they would form the two pyramids. In between, you see a midline groove, if you notice, this midline depression. This is referred to as the anterior median fissure. Anterior because it's ventrally placed, median because it lies between the two pyramids, and it's a fissure, it's a groove. So, the anterior median fissure contains the anterior spinal artery, which provides blood supply to the medial medulla. This is very important. I'll be revisiting this concept multiple times. However, this will help you later on. So the anterior spinal artery sits within the anterior median fissure and provides blood supply to the medial medulla. And we'll see the structures that are associated with the medial medulla. Other important structures include the olive. So the olive is an olive-shaped protrusion, just lateral to the pyramids, if you notice. And it corresponds internally to the inferior olivary nucleus, which we'll be seeing later on. So you have the pyramids here, you have the olives. Now that's it for the medulla in terms of the major anatomical landmarks. When you come to the pons, which is again the bridge that connects the two cerebellar hemispheres, you have a central midline groove, which is referred to as the basilar sulcus. The basilar sulcus contains the basilar artery. And the basilar artery provides blood supply to the ventral pons especially. So the ventral pons, meaning the anterior-most portion of the pons, is supplied through the basilar artery. And this is very important because this will correlate to lesions. If you have occlusion of the basilar artery, you would expect a particular combination of symptoms. So that's it for the pons. Again, you also see a striated type of pattern, which we'll discuss in details later on. The most superior or the most rostral part of the brainstem would be the midbrain. If you see, we have two stalk-like structures, two tubes that connect to the pons and the lower portions of the brainstem to the forebrain. They're referred to as the cerebral peduncles. A peduncle is essentially a collection of nerve fibers or axons that connect structures or supply structures, depending on the type of tract we are talking about. So that's it for this ventral view. Of course, we see the cranial nerves, which I'll discuss in the following slides. Now, this is very important. This helps you understand the general organization of structures, in the brainstem when it comes to the cranial nerves especially. So let's get some definitions right. Write this down if you want. So when it comes to a tract is a collection of nerve fibers or axons in the central nervous system. So in the brain and the spinal cord exclusively, okay? This is opposed to a nerve. A nerve is a collection of nerve fibers or axons in the peripheral nervous system, so outside the brain and the spinal cord. So the cranial nerves, they arise from the brainstem, and they exist outside the brain, and hence they're referred to as nerves because they're collections of multiple nerve fibers that form this bundle. On the other hand, if you look at the cell bodies part, you have nuclei. A nuclei is a collection of cell bodies in the central nervous system. That's a very important definition because it helps you understand the ideas. A nucleus is a collection of cell bodies in the central nervous system. A ganglion is a collection of cell bodies in the peripheral nervous system. So, okay, when it comes to this slide, this is a very important tip. Cranial nerves are numbered in top-down fashion, okay? So now we have 12 cranial nerves, okay? We have the olfactory, the optic, the oculomotor, the trochlear, the trigeminal, the abducent, the facial, the vestibulocochlear, the glossopharyngeal, the vagus, the accessory, and the hypoglossal. So they're numbered in top-down fashion, meaning the third cranial nerve, the oculomotor, if you see here, we have the two cerebral peduncles, which I discussed previously. It arises most superiorly. This is opposed to the fourth cranial nerve, which is the trochlear nerve. It arises from it's the only cranial nerve that arises from dorsal brainstem. That's a very important point. It's the only cranial nerve that arises from the dorsal aspect, meaning the posterior aspect of the brainstem. So you see 3, 4, 5, 6, 7, 8, 9, 10. So they're numbered in top-down fashion. So if I have a lesion that affects the third cranial nerve or the oculomotor nerve, namely, I would expect it to be associated with the midbrain because it's most superior in position. So yeah, so keep in mind the oculomotor nerve, again, fourth would be the trochlea. The fifth at the level of the pons would be the trigeminal nerve. Okay, as the name implies, trigeminal, three. So you have three principal branches of a trigeminal nerve, the ophthalmic, the maxillary, and the mandibular, which we'll discuss later on. We have, as you progress downwards, apart from the trigeminal, we have the abducent nerve. The abducent nerve arises from the ponto-medullary junction. So you have a junction between the pons and the medulla. This is the ponto-medullary junction, or the ponto-medullary sulcus. The most medial nerve to arise is the abducent. It's very medial in position. If you look to lateral, just lateral actually to the abducent nerve, you have the seventh cranial nerve, the facial nerve. Just lateral to it, you have the eighth, which is the vestibulocochlear nerve. So we have 3, 4, 5, 6. When you get to 6, we count laterally. So 6, 7, and 8. Now, if you move to the level of the medulla, you would see the ninth cranial nerve, the Glossopharyngeal, which arises superior to the vagus, okay? Because again, it's numbered in top-down fashion. So 9 comes superior to 10, and 10 comes superior to 11. 10 would be the vagus, 11 would be the accessory nerve. Now, I talked about the pyramids here. In between the pyramid and the olive, you have the 12th cranial nerve, the hypoglossal nerve. And I'll discuss the function in the following slide, but just keep in mind, this is very important for your OSPE, but cranial nerves are numbered in top-down fashion. That's it for external features 2. For external features 3, when you're looking at a dorsal view of the brainstem, so you're looking at the brainstem from behind. The cerebellum is reflected, like it's removed, and you're looking at this diamond-shaped cavity. It's very unique. Diamond-shaped cavity. It's the fourth ventricle. The fourth ventricle corresponds to the medulla and the pons. So I'll start from the lowermost aspect. Again, most inferior, you have the medulla. Then superior to it, you have the pons. And then finally, you have the midbrain, the most superior part of the brainstem. If you look, we have some important landmarks we need to focus on. We have two projections. We have two protrusions that they point backwards. They're referred to as tubercles. So the gracile and the cuneate tubercles, they correspond to dorsal column nuclei. You know, the dorsal column, we have nerve fibers that ascend through the dorsal column and get to the brainstem, specifically the medulla. In the medulla, they synapse onto dorsal column nuclei, okay, namely the nucleus gracilis, which corresponds to the gracile tubercle, and the nucleus cuneatus, which corresponds to the cuneate tubercle. And they form these two protrusions because, again, what's a nucleus? A nucleus is a collection of cell bodies in the central nervous system. So we have cell bodies of the second order neurons of the dorsal column. I'm discussing this shallowly because we'll get to it later on in terms of the exact pathway and whatnot. Of course, we see the fourth ventricle. This whole cavity is the fourth ventricle. Now, this is very important. The cerebellopeduncles. We have 3 pairs of cerebellopeduncles. We have the superior cerebellopeduncles. We have the middle cerebellopeduncles. And we have the inferior cerebellopeduncles. So this would be the superior cerebellopeduncle, the middle cerebellopeduncle, which is the largest out of the 3. And we have the inferior cerebellopeduncle. The superior cerebellopeduncles connect the midbrain to the cerebellum, as the name implies. The middle cerebellopeduncles connect the cerebellum to the pons, and the inferior cerebellopeduncles connect the medulla to the cerebellum. And again, a peduncle, when you see peduncle, this term, it's a collection of nerve fibers, typically white matter. So myelinated axons that connects two structures or supplies a particular, structure. Now, again, we discussed the gracile and the cuneate tubercles corresponding to the dorsal column nuclei. Again, collectively, when I say dorsal column nuclei, it refers collectively to the nucleus gracilis and nucleus cuneatus. Okay. Now, when it comes to the pons, when you look at it dorsally, apart from the fourth ventricle, you see 2 protrusions, okay? 2 elevations, referred to as the facial colliculi. A colliculus is a little hill. It's Latin for little hill. And it corresponds to the facial nerve looping around the abducent nucleus. So if you imagine the abducent nucleus, the facial nerve, before exiting the pons, it actually loops around it. It loops around the abducent nucleus, producing a bump in the posterior aspect or the dorsal aspect of the brainstem. Generally, external features, they're not that critical, but it helps you to connect the ideas. You mostly get asked on lesions in the exam. Now, forget about the pons. We finished with the pons. if you look at the level of the midbrain, we have four little hills. We have four protrusions from the midbrain. We have the superior colliculus here, and we have the inferior colliculus here. Okay, what I need you to memorize, just know it by heart. The superior colliculus is responsible for visual reflexes. Okay, at the level of the upper midbrain, and the inferior colliculus is responsible for auditory reflexes. So it's related to the hearing system, okay, to the cochlear pathways, which we'll discuss later on. And it makes sense. If we have a superior colliculus, we have an inferior colliculus. So the superior colliculus would be the center for visual reflexes. The inferior colliculus would be the center for auditory reflexes. And yeah, here you have a portion of the thalami. Again, remember the brainstem connects like the spinal cord, which is more inferior in position, or more caudal in position, to the thalamus. And that's it for, again, the dorsal view. Now, this is very important. This is, if you need to know this very well. If you know nothing but this, you'll be able to solve the majority of questions. The functions of the cranial nerves, okay, generally. Now, we're not really concerned with the olfactory and the optic because, again, they connect directly to the cerebrum, so the upper centers of the brain. We're primarily concerned with the functions of cranial nerves 3 through 12, all of them, and their associated clinical deficits or, lesions, okay? So I'll start with, again, the olfactory obviously is responsible for smell, the sense of smell, which is a special sense. We have the optic, which is responsible for vision, so it connects to the retina directly. But again, it connects to the cerebrum, so higher lobes. Now, the oculomotor is the first important cranial nerve we need to discuss. Again, it's the third cranial nerve, as the name implies. Oculomotor, meaning it's motor to the extraocular muscles. The extraocular muscles are, again, they're a specialized group of muscles responsible for eye movements. Okay, so when I want to look upwards, when I want to look to the side without moving my head, when I want to look downwards, okay, when I want to look sideways, this is a function of the oculomotor nerve. It's motor actually. It supplies all extraocular muscle except for two muscles I'll be focusing on, the lateral rectus and the superior oblique. The oculomotor supplies all extraocular muscles of the eyeball responsible for movements except for the lateral rectus and the superior oblique. So this includes stuff like the superior rectus, the inferior rectus, the medial rectus, and the inferior oblique. Now, apart from this function, okay, it also has other important functions. The first being pupillary constriction. So if I come and artificially stimulate the oculomotor nerve, I would have pupillary constriction, meaning miosis. The medical term for pupillary constriction is miosis. Why? Well, the oculomotor nerve supplies a bundle of smooth muscles, okay, called the sphincter pupillae muscle. Okay, the sphincter pupillae muscle is a sphincter-like muscle, meaning it surrounds the pupil. Once it contracts, it would cause pupillary constriction. So again, sphincters typically, once they constrict, they narrow the structures. So you have pupillary constriction mediated by the sphincter pupillae muscle, which is a collection of smooth muscles. And it's also important for accommodation. What is accommodation? Accommodation is simply, okay, I'm looking far away, okay, at the sea, let's say, and I want to refocus my gaze at a closely placed object. This is accommodation. It's a function of the ciliary muscle. Okay, so the oculomotor nerve supplies the ciliary muscle. The ciliary muscle is another bundle or group of smooth muscle fibers that makes the lens more convex. Okay, so once it contracts, it makes the lens more convex to accommodate for near vision so that you can refocus your gaze at a closely placed object. Another muscle that the oculomotor nerve supplies is the LPS, levator palpebrae superioris. Levator because it elevates the eyelid. So when I close my eyes and I elevate it, that's a function of the levator palpebrae. Palpebrae simply means eyelid. So it's an upper eyelid muscle that is responsible for opening your eyes. So you can expect, with all likelihood, if I damage the oculomotor nerve, you would have paralysis of the levator palpebrae superioris, and you would end up with ptosis, which is eyelid drooping. Okay, it would be difficult to open your eyes. So again, recap for the oculomotor nerve: it supplies all extraocular muscles except for the lateral rectus muscle and the superior oblique. It is responsible for pupillary constriction, okay, meaning miosis, through the sphincter pupillae. It's also responsible for accommodation, which is, again, refocusing your gaze at a closely placed object through the ciliary muscle. And it's also responsible for eyelid opening through the levator palpebrae. Again, it's a purely motor nerve, meaning it has no sensory component whatsoever. We move to the fourth cranial nerve, the trochlear nerve. Now, the trochlear nerve is very simple. It supplies a single extraocular muscle. I told you that the oculomotor supplies all extraocular muscles except for two. Well, the trochlear nerve supplies the superior oblique. Okay, the trochlear nerve, the fourth cranial nerve, supplies the superior oblique, and the superior oblique is responsible for, depression, meaning moving your eyeball downwards when the eyeball is adducted. So we have eyeball adduction, which is medial deviation. Okay, so looking, towards your nose, and we have eyeball, abduction, which is lateral deviation. So the superior oblique is responsible for, depression when the eye is adducted. So looking downwards, like bottom right corner for the right eye. Like for example, when you're reading a book or traveling down the stairs. Again, it's a purely motor nerve, supplies a single extraocular muscle, which is the superior oblique. That's it for the trochlea. I'll skip the trigeminal because it's a heavy nerve. I'll come back to it later. The abducens is the third cranial nerve that supplies extraocular muscle. It also supplies a single extraocular muscle referred to as the lateral rectus. The lateral rectus inserts onto the lateral aspect of the sclera, or the eyeball. Once it contracts, it pulls the eyeball laterally. So that's eye abduction. Lateral rectus is responsible for eye abduction, so lateral deviation. Okay. So the three cranial nerves responsible for extraocular muscle supply, motor, the oculomotor, the trochlea, and the abducens. As the name implies, by the way, abducens, because it mediates abduction. It mediates eye abduction. Now, for the trigeminal, again, it's a purely motor nerve. For the trigeminal, or the fifth cranial nerve, it's a mixed nerve, meaning it has both sensory function and motor function, both. But its primary function is sensory. Okay, so it's actually the most important nerve that supplies the face with somatic sensations or general sensations. What are general sensations? General sensations include stuff like pain, temperature, two-point discrimination, vibration, and conscious proprioception, all of which are only made possible through the trigeminal nerve. It supplies the whole facial region, the facial skin, the facial, even a part of the oral cavity. So again, facial sensation, that's the primary function. Again, because it has three major divisions, as we said previously. You have the ophthalmic, which supplies this upper portion of the face. So think about the forehead, even portion of the eyeball. The maxillary, which corresponds to the maxillary region. Think about it like the nose and the cheek, and the mandibular division, which supplies the lowermost portion of the face. Now, and so what is somatosensation? Somatosensation is, again, things like pain, temperature. Somatic sensations include pain, temperature, two-point discrimination, vibration, pressure, and so on. Now, it's also sensory, general sensory. So we have two major categories of sensations, either general sensations or special sensations. General sensations are ordinary. They're pretty present throughout the body. And I talked about them like pain, temperature. They're also present in the body. Special senses require specialized organs and specialized epithelium in the head and neck region. What do I think about? I think about the olfactory epithelium. I think about the retina, which is specialized. I think about the NEU structures, which are specialized. Again, they're specialized organs dedicated to that special sense. Special sense. So the trigeminal is also responsible for somatosensation from the anterior two-thirds of the tongue. Okay, so general sensations and not taste. We'll come to this later. Now, why did I say it's a mixed nerve? The trigeminal is also motor to the muscles of mastication. What is mastication? Mastication is chewing. It's the fancy medical term for chewing. Okay. So when you want to close your jaw, when you want to move your jaw sideways, for example, this is very important for oral digestion. So this is physical digestion. You're churning the food. So the trigeminal nerve, through the third branch, actually, the mandibular nerve, supplies the muscles of mastication. Okay, and that's it for the trigeminal. We're talking about the abducens, again, mediating eye abduction through the LR or the lateral rectus. Then we have the facial. The facial is the seventh cranial nerve. Its major function is motor supply to the muscles of facial expression. So when you smile, when you frown, when you raise your eyebrows, when you close your eyes, when you show your teeth, that's all function of the facial nerve because it produces facial expression. It's also responsible for eyelid closing, and the orbicularis oculi is a circular muscle that surrounds the orbit or the eye region. And once it contracts, it closes the eyes. Okay, so we conclude from this, for opening the eyes, you need the oculomotor through the LPS, the levator palpebrae superioris muscle, and for the facial, it mediates closure, eyelid closure, through orbicularis oculi. Now, it also supplies, a small muscle that is found within the inner ear, and it's very important because it mediates auditory volume modulation. What do I mean by this? This muscle is referred to as the stapedius. Okay, the stapedius is involved in the protective mechanism to prevent overwhelming loud noises from damaging your inner ear structures, such as the cochlea. So the stapedius, once it contracts, it actually prevents full transmission of sound energy to the inner ear structures, especially if it's pretty loud noise. And hence, this allows you to protect your inner ear structures. So in terms of motor supply, it's motor to the muscle of facial expression, plus of course the stapedius. It's also sensory. Okay, it has sensory function. Its major sensory function is that it provides taste to the anterior 2/3 of the tongue. So it supplies the anterior 2/3 of the tongue with taste. We said that the trigeminal supplies the anterior 2/3 with somatosensations or general sensations, so pain, temperature, and whatnot. And now we say that facial supplies the anterior 2/3 of the tongue with taste. Okay, so if I have partial loss of taste from the anterior 2/3 of the tongue, what would I expect? This would be a lesion of the facial nerve. Okay, through the chorda tympani, which is a branch, not critical for neuro. Now, the facial also contains a parasympathetic component to supply some important glands in the head and neck region. So we have two major groups of glands. We have the lacrimal gland, which is responsible. It sits here above the eyeball. It's responsible for tear production or lacrimation. Okay. On the other hand, we also have salivatory glands. So the submandibular gland, the parotid gland here, the sublingual gland, all of them. We have three major salivary glands: the submandibular, the sublingual, and the parotid. Now, the facial nerve supplies the lacrimal gland through the parasympathetic component, which we'll discuss again later on, and induces lacrimation. Okay. It also supplies the submandibular and sublingual glands. Okay, which again, mediates salivary secretion and production of saliva for chemical digestion of food. So let's say I have a lesion that affects the facial nerve. Most notably, I would have facial paralysis. So paralysis of muscle facial expression on one side. When I ask the patient to smile, for example, there would be clear asymmetry between the two sides of the face. Okay, that's one. Secondly, the patient will have loss of taste from the anterior 2/3 of the tongue. Okay, so the posterior 1/3 is still functional in terms of taste. However, you have partial loss of taste from the anterior 2/3. Apart from this, we also have loss of lacrimation. So you wouldn't be able to produce tears, and hence you would have dry eyes. You would have ipsilateral dry eyes. And you would have decreased salivary secretion. So you could have a dry mouth, for example. And that's for the facial. The vestibular-cochlea is more head and neck material, but as the name implies, vestibular-cochlea, we have two divisions. We have the vestibular division, and we have the cochlea division. The vestibular division is responsible for the sense of balance. Okay, so your head position in space, again, it's very important to notice where your head is positioned in space. Otherwise, you'll end up with signs like vomiting, nausea, and dizziness, vertigo. You will feel like the room is spinning around you. Okay. You also have the cochlea division. The cochlea division is very simple. It's hearing function. Okay. So if I damage the vestibular cochlea nerve, I would expect dizziness, so vertigo, and also deafness or loss, hearing loss simply. Again, it's purely sensory. It's a special sense because it connects to the inner ear, which is a specialized structure. Then we come to the ninth, the Glossopharyngeal. If you remember from our previous images, it arises from the medulla. It's responsible for taste and general sensation from the posterior 1/3 of the tongue. So we said that the facial is responsible for taste from the anterior 2/3. We said that the trigeminal is responsible for general sensations from the anterior 2/3. And we said that the Glossopharyngeal is responsible for taste and general sensation, both from the posterior 1/3 of the tongue. Okay, so that's an important function. And hence it's both. It's a mixed type of nerve. Okay, I'll come to the motor functions. Now, the glossopharyngeal is also important because it supplies a single muscle referred to as the stylopharyngeus. The stylopharyngeus is a muscle that allows for the elevation and contraction of the pharynx. So when you put food substance within the mouth or within the pharynx, the ability to contract and propel the food downwards into the esophagus, it's partially done by the stylopharyngeus. So if I have damage to the glossopharyngeal nerve, I would expect dysphagia or mild difficulty with swallowing. Now, that's it for swallowing. It also supplies the parotid gland. I said we have three major salivary glands in the head and neck region. the parotid, which is the largest. We have the submandibular and sublingual. So parotid, submandibular, and sublingual. The submandibular and sublingual glands are supplied by the facial nerve, as we said previously. The glossopharyngeal supplies the remaining one, which is the parotid gland. Okay, it's also responsible for monitoring, the carotid body and sinus chemoreceptors and baroreceptors. What does this mean? Okay, so simply within the aorta, you have specialized receptors. They're responsible for detecting blood pressure. So if you have a massive rise in blood pressure, you need to reflexively lower the blood pressure. Same applies for blood pH. When you have, for example, the blood, let's say the blood became too acidic, okay, too much H+. Then you need to detect this through the chemoreceptors within the aorta, and the glossopharyngeal picks on this. So it's sensory from these receptors within the aorta. And hence it's a mixed type of nerve. Now for the vagus, again, vagus is Latin for wandering because it's a very extensive nerve. It's responsible for approximately 75% of parasympathetic supply in the whole body. Imagine. Now, in terms of vagus, the most important function would be swallowing, okay, and soft palate elevation. So, the vagus nerve is motor to the muscles of the pharynx, the larynx, and the soft palate. So, 3 groups of muscles. So, by definition, if it's motor to the muscles of the pharynx, it's involved in swallowing. If it's motor to the muscles of the larynx, the voice box, which is responsible for sound production, it's also responsible for phonation or producing sound, so talking. If I had damage to the vagus nerve, I would expect dysphagia, so difficulty swallowing, and also dysarthria or hoarseness, where I produce too weak a sound. So it supplies the soft palate, the midline uvula, which is again this. I'll show you later on, but it's a collection of striated muscle within the mouth. Again, it's also responsible for taste from the supraglottic region. So I divided the tongue into an anterior 2/3, a posterior 1/3, and also you see the epiglottis is like a paper that shuts the larynx when you want to swallow. Okay, the dorsal aspect or the supraglottic region, it contains actually taste receptors. It contains taste receptors because once the food passes, it actually slides down the dorsal aspect of the epiglottis. Okay. And hence it contains some taste receptors. And this part is very minor taste function, but it receives taste from the supraglottic region. It's responsible again for supply to the soft palate. So soft palate elevation, which is again a collection of striated muscle, midline uvula, talking because it supplies the vocal cord muscles. It's also responsible for the cough reflex, which we'll discuss in details more later on. So when you swallow something incorrectly and it gets into the bronchial tree or into the carina, the ability to propel the food out of the bronchial tree is also a function of the vagus nerve, by the way. Most importantly, it provides the parasympathetic supply to the thoraco-abdominal viscera, meaning the thorax and the abdomen, up to 2/3 of the transverse colon. So this includes stuff like the bronchial tree or the lungs. When you want to induce bronchoconstriction, that's a function of the vagus nerve. Okay. When you want to slow the heart rate, so you want to induce bradycardia, that's a function of the vagus nerve because again, it's a parasympathetic nerve. So we would have release of acetylcholine near the heart, and this will induce slowing of the heart rate. Okay, as in, for example, you want to regulate blood pressure. Okay, so very important. Vagus nerve, parasympathetic supply to the thoraco-abdominal viscera up to 2/3 of the transverse colon. Again, it has similar function in terms of sensory to the glossopharyngeal, monitoring aortic arch, chemo, and baroreceptors in terms of like blood pH and blood pressure. Now, for the accessory, it's a very easy nerve to know. However, you need to know a couple of things about it. It's the 11th cranial nerve for starters. The accessory, as the name implies, it supplies 2 muscles. So the accessory nerve supplies 2 muscles. For starters, it supplies the trapezius muscle and the sternocleidomastoid. So 2 muscles, the trapezius, okay, and the sternocleidomastoid. Now, the sternocleidomastoid is a muscle that is responsible for turning the head away from the contracted muscle. So let's say that's my right sternocleidomastoid muscle. I want to turn my head towards the left. Once the right sternocleidomastoid muscle contracts, I would turn my head towards the left. Okay? So that's done by the accessory nerve. Another function is supplying the trapezius. So the trapezius is responsible for the shrugging motion, this shrugging motion. Okay? So if you go to the gym, actually, the trapezius is trained through shrugs. So you hold dumbbells and you just, try to shrug the weight. So if I have a lesion that affects the accessory nerve, what would I expect? Okay, for starters, I wouldn't be able to turn my head away from the lesion. Okay, so I would have muscle weakness in the right sternocleidomastoid. Let's say the right accessory nerve is damaged. Okay, you have a lesion that affects the right accessory nerve. Okay, you would end up with difficulty turning your head to the left, towards the opposite side of the lesion. Okay, that's one. Secondly, you would have a drooping of the shoulder. The shoulder would be, drooped compared to the other side. So the right accessory nerve is damaged. We have a lesion that affects the right accessory nerve. Then I would expect, ipsilateral drooping of the shoulder. So it would droop on the same side relative to the lesion. And also, I wouldn't be able to turn my head towards the opposite side of the lesion. Okay. Again, it's a purely motor because it supplies skeletal muscle. So yeah. Now, finally, for the hypoglossal, as the name implies, hypoglossal, glossus means tongue. So it provides the motor supply to the intrinsic tongue muscles. So any type of tongue movement is mediated through the hypoglossal nerve. Okay. So if I have damage to the hypoglossal nerve, I would have weakness involving the tongue muscles, the intrinsic tongue muscle responsible for, again, protrusion, like this way, like moving the tongue sideways. It's all a function of the hypoglossal nerve. And yeah, that's it for the cranial nerves, the most important 3 through 12. Now you can memorize this mnemonic in terms of like to know which are motor and which are mixed, which are sensory. So some say marry money, but my brother says big brains matter most. B stands for both, so both motor and sensory function. S stands for sensory function, and M stands for motor function. Okay, yeah, that's it for cranial nerve function 1. Again, this is a nice image. It's a visual anchor to explain what I'm talking about. Again, olfactory and optic, you think cerebrum, so we're not really that involved with them. For the oculomotor, remember, it supplies all extraocular muscles, so this includes all of them except for the lateral rectus, which is this muscle, by the way, supplied through the abducent, and the superior oblique. Okay, the superior oblique is this tiny muscle. Okay, the oculomotor nerve is very important. It supplies all extraocular muscles except for LR6SO4. This is a mnemonic you can use. LR6, meaning the lateral rectus supplied through the abducent because it's the 6th cranial nerve. And SO4, superior oblique, is supplied through the trochlear nerve, which is the 4th cranial nerve. So as we said, cranial nerve 3, 4, and 6, they're responsible for extraocular muscle control or eye movements. And the oculomotor has an additional function, which is pupillary constriction through contraction of the sphincter pupillae, if you remember. Okay, that's the 3rd cranial nerve. If you look at this image, it arises at the level of the midbrain. Okay, so upper brainstem. When it comes to the 4th, again, we're talking about the 4th supply. Again, prochlea supplies to the superior oblique. Same applies for the abducent, supplied to the lateral rectus. The 5th cranial nerve, the trigeminal. Again, you have a motor rootlet and you have a sensory rootlet motor to the muscles of mastication. So you see the muscles of mastication. This is the temporalis muscle. You can feel it actually when you try to close your jaw and do this. Okay, you would see that there's contraction here. This is the temporalis muscle, and it's one of the muscles of mastication. It's responsible for chewing, again, physical digestion. So this is the temporalis. Sorry, that's the temporalis muscle. That's the motor function of the trigeminal. However, the major function of the trigeminal is that it's sensory to the face. So here we have the ophthalmic division. We have the maxillary division, which supplies the majority of the cheek and the lower eyelid, even the upper teeth. And we have the mandibular division, where you have supply of this whole region. Okay, sensory supply. Remember, again, somatosensation, general sensations, so pain, temperature, 2-point discrimination, vibration, conscious proprioception, all are a function of the trigeminal nerve. Yeah. So the 2 most important functions of the trigeminal nerve are, facial sensations and its motor to the muscle of mastication, including, the masseter, the temporalis, and whatnot. Again, it's also general sensory to the anterior 2/3 of the tongue. So again, if you can't feel temperature, so hot or cold food from the anterior 2/3, that's a function of the trigeminal. Okay. Now for the 6th, we're talking about the 6th actually, the abducent nerve supplied to the lateral rectus. Remember, LR6. Then we proceed to talk about the facial nerve, the 7th. Okay. So the facial lies lateral to the abducent, if you notice. That's the abducent, which is medial in position. That's the facial. Again, major function supplied to the muscles of facial expression, so including the muscles of the forehead responsible for frowning or raising your eyebrows, the orbicularis oculi responsible for eyelid closure, the muscles that are responsible for smiling, blowing, and whatnot. It's also responsible for supply to the submandibular sublingual glands against salivation. It's also supplying the lacrimal gland for tear production. So again, we have some glands that are supplied by the facial nerve. For the vestibular cochlea, we said, again, hearing, balance, and equilibrium. So vestibular function equals balance and equilibrium. and hearing function equals cochlear function. Simple. The Glossopharyngeal, think about supply to the stylopharyngeus involved in swallowing. It's also involved in the gag reflex, actually, which we'll discuss later on. It's also involved in salivation because it supplies the parotid gland, third salivary gland, if you recall. Now, when it comes to the vagus, same thing. As I told you, the most important function would be supplied to the thoraco-abdominal viscera, including the heart, the lungs, the GI tract, the smooth muscle of the GI tract responsible for peristalsis, up to 2/3 of the transverse colon. Again, that's a function of the vagus, apart from, of course, phonation, which is production of sound. So when you talk, your voice is now weak. That's a function of the vagus because it supplies the vocal cords, and also swallowing because it supplies the majority of the pharyngeal muscles involved in propelling the food into the esophagus. Again, accessory, supplied to sternocleidomastoid trapezius, and hypoglossal, very simple, supplied to the tongue. Okay, and remember, the cranial nerves exist as pairs. So we have a right-sided accessory nerve and a left-sided accessory nerve. The right-sided accessory nerve would supply, the right-sided sternocleidomastoid and trapezius. The left-sided accessory nerve would supply the left-sided sternocleidomastoid and trapezius. So that's the overview of the cranial nerves. Again, this is what I talked about. It's a good mnemonic to help organize your thoughts when it comes to ocular motility. So these, muscle groups, this muscle group specifically referred to as the extraocular muscle group. Extraocular because they lie outside the eyeball. This is the eyeball. This is the sclera, the white stuff. These muscles attach to the eyeball and allow for eye movements, either upward, downward, laterally, medially. And you can see, for example, let's say the medial rectus muscle, it's medial in position. So this is the medial rectus muscle. Once it contracts, it pulls the eye to the medial aspect. Okay, so that's eye adduction. The lateral rectus plays the opposite role. The lateral rectus would attach to the lateral aspect of the eyeball and pull the eyeball laterally. So that's abduction. Okay, supply through the abducen. So the mnemonic I want you to remember, again, same thing as I said, cranial nerve 6 supplies, the lateral rectus muscle, LR6. Okay, and cranial nerve 4 supplies the superior oblique, SO4. So LR6, SO4, and all other extraocular muscles are supplied through the oculomotor. So the only two extraocular muscles that are not supplied by the oculomotor, the third cranial nerve, would be the lateral rectus and the superior oblique. And this will become important lesions, especially. So if I have a deficit, that affects the lateral rectus muscle, I'm unable to move my eye laterally, right? So I would have unopposed action of the medial rectus muscle, and it will be medially deviated. The eye will be medially deviated. Okay, this is a scenario where you have a lesion that affects the lateral rectus or the abducens nerve, LR6. Remember, so just know this, and you'll be able to answer any question about eye movements and lesions corresponding to the third, the fourth, and the sixth cranial nerves. Yeah, and that's it for this part. Now, okay, this is a very important part. This is the functional classification of cranial nerve fibers. So generally, again, I'll be dividing. This is a principle slide, a concept slide, and then we'll proceed to discussing the table in details. Concept 1 outlines that nerve fibers or axons are classified based on the targets they supply. So if you have two broad categories, they are either motor or sensory. They either relay sensations from the periphery, so the face, for example, or they are motor to a particular structure that elicits a function. So, for example, this could include smooth muscle. This could include striated muscle, skeletal muscle. This could include, submandibular, sublingual glands, salivary glands, or even lacrimal glands. So the nerve fibers or axons are classified. So they're grouped into bags based on the targets they supply. Could be smooth muscles, glands, skeletal muscle, or the sensation they carry. So again, we have two major categories of sensations, as I said previously. You have general sensations or somatic sensations, which include pain, temperature, two-point discrimination, vibration, and conscious proprioception. They're ordinary functions. They're ordinary sensory functions. And we also have special senses. So special sensory functions. This includes vision. This includes olfaction, so smelling. This includes hearing or audition. This includes taste. All of them are special functions, and hence they're said to be special. That's the first concept. Okay. Concept 2 would be that a single cranial nerve, so for example, the facial, okay, it can contain multiple fiber types. So it can be mixed. It can contain both motor and sensory fibers, okay? It could be motor, sensory, special motor, or special sensory, depending on the targets they supply. Again, the classification is based on the targets they supply. The easiest example I can think about would be the oculomotor nerve, the third cranial nerve. Okay, the third cranial nerve, supplies the extraocular muscles, except for LR6 SO4. So that is, somatomotor, okay, or I'll come to discuss this, or GSE fibers, okay, GSE fibers. And the second component of fibers, or the second category of fibers would be, what do you call it? The second category of fibers would be the parasympathetic fibers, or the visceromotor fibers that supply the pupil. Okay, so it mediates pupillary constriction, which is meiosis, and also accommodation. So in this case, you see that oculomotor contains two different fiber types, even though both are motor. You have GSE fibers and you have GVE fibers. Again, GVE, autonomic efferents, so motor to smooth muscles and glands, and hence this is a very important point. Single cranial nerve can contain multiple fiber types. Concept 3. Motor fibers or nuclei are organized medially in the brainstem. So motor fibers arise generally. Motor cranial nerves arise from within the brainstem, okay, medially. This is opposed to sensory fibers or sensory nuclei, which arise laterally. Okay, that's a very important point. We'll revisit this multiple times in cross sections and lesions. So, for example, given that the abductor nerve is a purely motor nerve, meaning it only supplies the lateral rectus muscle, I would expect it to be medially in position to the vestibular cochlea. The vestibular cochlea is purely sensory, and hence it's lateral in position relative to the abductor. And these three concepts are very important because we'll revisit them multiple times. That's the first slide. The second slide would be, again, the motor fiber types. So again, by definition, a motor fiber is a fiber or it's an axon that goes from the central nervous system, the brain, the spinal cord, whatever, to the periphery, to supply a structure, to elicit a function, to produce a function. So smooth muscle contraction, skeletal muscle contraction, and whatnot. Okay, so that's a very important point. We have three major, categories of, fibers, motor fibers specifically. We have GSE fibers, GVE fibers, and BE fibers. I'll explain what does this mean exactly. General somatic efferent. General, okay, so when it comes to the classification of motor fibers, we have two major groups of skeletal muscles in the head and neck region. Okay, we have somite-derived skeletal muscles, which are, again, somites are embryological structures that give rise to, skeletal muscle. And we also have another group, which is branchial arch-derived skeletal muscle. So the GSE fibers supply somite-derived skeletal muscle. And you have two muscle groups you need to keep in mind. We have the extraocular muscles, okay? The extraocular muscles responsible for eye movements, and we have the intrinsic tongue muscles, both of which are supplied through the GSE fibers. For the intrinsic tongue muscles, we talked about this, the hypoglossal nerve, for example. For the extraocular muscles, they're supplied through the three cranial nerves I discussed beforehand, the oculomotor, the trochlea, and the abducent. They're said to be somatically derived or somite-derived, and hence they're supplied through GSE fibers. So if you look at the table, GSE, skeletal muscles from somites. For BE or branchial efferent, again, when you see BE, SSE, SVE, they're synonymous. Okay, they're essentially synonymous. It's the same type of fiber. They're only different terms. But why do I prefer to use the term branchial efferents? Because it's supplied to branchial arch-derived skeletal muscle. So in the head and neck region, especially, we have special muscles that are derived from pharyngeal arches or branchial arches. They include the muscles of facial expression, the muscles of mastication, the muscles of the pharynx and larynx. They're all derived from branchial arches. So the nerve fibers that supply branchial arch-derived skeletal muscle include, they're said to be SSEs, SVEs, or BEs, which are branchial efferents. Okay. Now, finally, you have the third category of nerve fibers, which is GVE, general visceral efferent, which is synonymous with parasympathetic fibers. So parasympathetic fibers generally in the body, they supply smooth muscles. An example would be the sphincter pupillae muscle and the ciliary muscle supplied through the oculomotor nerve, and glands too. So salivary glands and the lacrimal gland. That's a very important point. For example, and also this includes again, the salivary glands include three major glands: submandibular, sublingual, and the parotid. And GVE or visceromotor, GVE fiber, general visceral efferent. Again, they are parasympathetic in nature. So you just need to memorize this. Again, GVE, smooth muscle and glands. I gave you a couple of examples. Same applies for SVE, SSE, or BE, which are branchial efferents or special somatic efferents or special visceral efferents. They all are the same. They supply the muscles of pharynx, the muscles of larynx, the muscles of facial expression, the muscles of mastication. That's it for the medial brainstem. Okay, we move to the arrangement of motor nuclei in in the brainstem. Okay, so this is very important. I said generally the motor nuclei are medially placed, okay, and sensory nuclei are laterally placed. So if we look at this diagram, okay, we are classifying motor nuclei based on their arrangement, medial to lateral. Okay, so the most medial in position, the most medial nuclear column, or the most medial motor column would be the GSE column, the somatomotor column. So again, general somatic effort, as we said previously, this includes two muscle groups, okay, or supplied to two muscle groups. We have the extraocular muscles, and we have the intrinsic tongue muscles, okay? The extraocular muscles are supplied by, again, the oculomotor, the trochlea, and the abducent. So if you go to the midbrain, the upper levels, again, we have cranial nerve 3. That's the, this is, this red nucleus at the upper level of the midbrain would be the oculomotor nucleus. It sends out GSE fibers to supply all extraocular muscles except for LR6-SO4. Same applies for the trochlea nucleus. If you notice, it's dead center as opposed to the other nuclear columns. So we can essentially group the motor nuclei based on their arrangement in the brainstem. Some are more medially placed, very close to the midline, and some are more laterally placed. So in terms of functions, again, extraocular muscles or intrinsic tongue muscles, the brainstem nuclei include the oculomotor at the level of the midbrain, the trochlea at the level of the midbrain too, the lower midbrain, and finally the hypoglossal here, at the level of, the medulla. Apart from this, you also have the abducent nucleus. The abducent nucleus sits within the pons. Again, it supplies the abducent nerve with the GSE fibers, the general somatic efferent fibers, to innervate the lateral rectus muscle, if you recall. Again, the associated cranial nerve fibers with the somatic motor column include cranial nerve 3, the oculomotor, trochlea, abducent, and hypoglossal. Now, apart from this, we also have just lateral to this general somatic efferent column, we have the GVE column, or the parasympathetic nuclear column. We have 4 major parasympathetic nuclei you need to keep in mind. They supply 4 major cranial nerves that have parasympathetic components. Okay, so the 4 cranial nerves that have parasympathetic components include the oculomotor nerve. Okay, that's one. Then you have the facial, okay, because it supplies the glands, the salivary glands, and the lacrimal gland. You also have the Glossopharyngeal, which supplies the parotid gland. And we finally have the dorsal motor nucleus of the vagus, which supplies, the vagus nerve itself. So the parasympathetic nuclei lie just lateral to the GSE column. Okay, so again, the level of the medulla, that would be the dorsal vagal nucleus. At the level of the pons, you would have the inferior salivatory nucleus. At the level of the upper pons, you would have the superior salivatory nucleus. And the level of the midbrain, especially the upper midbrain, you have the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the oculomotor nerve. So the Edinger-Westphal nucleus is the parasympathetic nucleus of the oculomotor nerve. The superior salivatory nucleus is the parasympathetic nucleus of the facial nerve, and the inferior salivatory nucleus is the parasympathetic nucleus of the glossopharyngeal. Because remember, it supplies the parotid gland, so it needs GVE fibers specifically. In terms of function, again, parasympathetic innervation of the head, so salivary glands and the lacrimal gland. And thoraco-abdominal viscera through the dorsal motor nucleus of the vagus at the level of the medulla. Okay. Again, Edinger-Westphal nucleus corresponds to cranial nerve 3, oculomotor responsible for pupillary constriction. Superior salivatory nucleus, again, supplied to the facial nerve, the 7th, to supply the submandibular and sublingual. Inferior salivatory nucleus supplied to the glossopharyngeal to supply, the parotid, and finally the dorsal motor nucleus for the thoraco-abdominal viscera up to 2/3 of the transverse colon. Okay. That's it for the parasympathetic nuclear column. So up to this point, the most medial, motor nuclear column is the GSE or the somatomotor column. Just lateral to it, you have the parasympathetic nuclear column or the GVE column, okay? And this corresponds to the cranial nerves I just discussed. Apart from this, most lateral in position, the most lateral motor nuclear column in position would be the branchiomotor column or the branchial efferent column or the special visceral efferent column or the SSE column. Again, it's synonymous. SSE, SVE, BE, all the same thing. In terms of nuclei at the level of the medulla, this is the most important one, arguably, the nucleus ambiguus. Okay, the nucleus ambiguus is motor to the muscles of the pharynx and larynx. So it's responsible for swallowing and talking, production of voice. If I have damage to the nucleus ambiguous, I would expect dysphagia and dysarthria. This is high yield. I'll be repeating this multiple times. Apart from this, so again, we have at the level of the lower pons, we have the facial motor nucleus. The facial motor nucleus supplies the muscles of facial expression, because again, the muscles of facial expression are derived from branchial arches or pharyngeal arches. Okay, so that is why it's classified as branchiomotor, or BE in other words. At the level of the upper pons, you have the trigeminal motor nucleus, okay, which ultimately supplies the muscles of mastication, okay, and these are the three, laterally placed branchial earphone nuclei. In terms of function, we revisit the table, supply to the muscles of mastication, the muscles of facial expression. Okay, we have a single muscle in the middle ear, which I discussed, if you remember, in the table. Facial nerve supplies the sapirius muscle. This is important for dampening the noise, for lowering the sound energy that gets into the inner ear structures. So it's a protective mechanism. It's also motor, again, the vagus, primarily through the nucleus ambiguous, is motor to the pharynx and larynx, so swallowing and phonation. And that's it. Again, this is not really that important. Again, muscles of mastication correspond to motor nucleus of trigeminal. Muscle of facial expression correspond to the facial nucleus or the facial motor nucleus. And the middle ear, which is, again, the sapirius, again, facial motor nucleus. You also have the muscles of the pharynx and larynx, primarily corresponding to the vagus, but also some glossopharyngeal, because the glossopharyngeal, supplies a single muscle, which is the stylopharyngeus, which I discussed previously. So, in conclusion, medial to lateral motor nuclei, GSE, GVE, BE, general somatic efferent, then GVE, which is general visceral efferent or parasympathetic, and finally branchial efferent or branchiomotor. That's for the motor nuclei. Now we'll proceed to talk about the sensory fiber types. So I just discussed the motor fiber types. The sensory fiber types originate from the periphery, so skin receptors, for example, or even specialized organs, and they project into the brainstem to relay the sensations. And we have two major categories of sensations. We have the somatic sensations, which include pain, temperature, two-point discrimination, vibration, and conscious proprioception. And we also have special senses, which include, again, hearing, balance, and equilibrium, olfaction, vision, all of the more special senses. So when it comes to a general visceral afferent, it relays visceral sensations. So as the name implies, general, visceral, meaning it relays sensations from the internal organs, namely the aorta, for example, or the GI tract. When you eat a large meal, let's say, and you have distension of the stomach, you have abdominal distension of the stomach, this will feed into the brainstem through the general visceral afferents. Okay, again, it's very important for gut distension, chemoreception, and baroreception. Chemoreception in case your blood pH drops or it becomes too high. Baroreception in terms of blood pressure. So that's the GVA component. If you look at the table, again, from visceral organs primarily, it allows for reflex regulation. This is very important. So if you have a massive rise in blood pressure, for example, you detect this through baroreceptors, so baroreception. It goes to the brainstem through the vagus and the glossopharyngeal, and hence you can reflexively regulate, slowing the heart rate, for example. That's the first category. The second category would be SVA, special visceral afferent. Just memorize this. Okay, special visceral afferent relay states from the tongue. Again, visceral, because if you imagine, the tongue is more like internal in position, okay, as opposed to for example, the ears and the eyes. That's how I remember it, at least. So it really states from the tongue. Again, special visceral afferents, or simply taste fibers. Okay, taste fibers. Again, we said that the facial, for example, carries states from the anterior 2/3, the glossopharyngeal from the posterior 1/3, and the vagus from the supraglottic region. They all possess special visceral afferent fibers. Finally, we move to the general somatic efferent, which is very simple. Again, general sensations, somatic sensations, again, very ordinary, but corresponding to the face. It relates to the somatic sensations from the facial region to the trigeminal nuclei in the brainstem, which we'll discuss in detail now. And again, this is not special, this is ordinary. Finally, we have special somatic afferent. It pertains to hearing and balance, so vestibulocochlear function. And that's it for this section. How do I remember it's somatic? And I imagine them as being more externally placed. So this helps me. Again, we'll not talk about olfaction and vision, because they correspond to the cerebrum, so it doesn't really matter. That's it for the lateral brainstem. Now again, sensory nuclei arrangement. Again, medial nuclei are motor, or motor nuclei are medially placed within the brainstem, and sensory nuclei are lateral in position. This is a very important point. Again, now we move to the sensory nuclei. Okay, we start with the GVE, column. Okay, there is a single nucleus you need to know about. It's just the caudal portion or the lower portion of the nucleus tractus solitarius. It connects to the vagus and it picks up the chemoreception, baroreception from the aorta, and also sensory functions from the gut if you have gut distension. So the lower portion of the nucleus tractus solitarius is GVA in function. Okay, so viscerosensory. Okay, however, the upper portion, of the the NTS, so the rostral nucleus tractus solitarius, is also referred to as the gustatory nucleus. Okay, it's very important you get asked about this. That's why I put bold on it. The rostral NTS receives taste sensations from the tongue. Okay, it receives input from the facial, the vagus, and the glossopharyngeal. So that's rostral NTS involvement. Yeah. Now, apart from GVE and SVA, you also have general somatic afferent, the general somatic afferent column, or the somatosensory column, the general somatosensory column, which corresponds to the trigeminal nuclei. You see these blue structures? Okay. These blue structures are collectively referred to as the trigeminal nuclei. Most inferior in position, you have the spinal trigeminal nucleus. Memorize this. The spinal trigeminal nucleus is responsible for ipsilateral facial pain and temperature. So ipsilateral pain and temperature from the face. So if I damage the right-sided spinal trigeminal nucleus, I would expect a right-sided loss of pain and temperature from the face. Okay, that's it for the spinal trigeminal nucleus. Now, if you see the upper pons, we see the principal sensory nucleus, or the chief sensory nucleus. It's responsible for ipsilateral, two-point discrimination, vibration, and conscious proprioception from the ipsilateral face. You need to know this. Again, it's just memorization. Spinal trigeminal nucleus equals pain and temperature from the ipsilateral face. Principal sensory nucleus, two-point discrimination, vibration, and conscious proprioception from the ipsilateral face. Similar to the dorsal column, but dorsal column corresponds to the body, obviously. And you have the mesencephalic nucleus, which is responsible for, what do you call it? Non-conscious proprioception from the muscles of mastication. Okay, so non-conscious proprioception from the muscles of mastication. Again, this column is somatosensory, so GSA, general somatic afferent. Sorry. Again, same thing: touch, pain, temperature, position, vibration, sense for face, sinuses, and meninges. Trigeminal nuclei, 3, principal sensory, spinal trigeminal, mesencephalic, and that's it. Then finally, you have the special somatic afferent. Just know, it's very important, at the pontomedullary junction, so the junction between the pons and the medulla, you have the vestibulocochlear nuclei, which are said to be special somatic afferent. Okay, so if I generally have a lateral medullary lesion or a lateral pontine lesion, you think about vestibular involvement, even potentially cochlear involvement. So let's say I have a lesion that affects the lateral pons. Okay, I would expect vertigo or dizziness because you have loss of vestibular function. Okay, and if the cochlear nuclei are involved, I would expect ipsilateral hearing loss or same-sided hearing loss or deafness. So again, medial to lateral recap, you have GVE, you have the caudal NTS, then the rostral NTS, you have taste function, okay, or the gustatory nucleus. Lateral to this, you have the general somatic afferent column, so think about the trigeminal nuclei, again, facial sensations. Then just lateral to this, actually the lateral most column would be the vestibulocochlear nuclei. You think about, again, as we said previously, vestibular sensation and, of course, hearing. And that's it for sensory nuclei. So let me drink some water. So what I need to emphasize is that motor nuclei are medially placed and lateral nuclei are sensory. Okay, motor nuclei are medially placed, sensory nuclei are laterally placed. Now, this is a question for you. Pause the video and try to answer it. I focus on something that comes with this question. A lesion involving the upper or rostral part of the right nucleus tractus solitarius would most likely result in which of the following clinical findings? Loss of pain and temperature sensation from the right posterior 1/3 of the tongue. That's an option. Okay. Loss of taste sensation from the right anterior 2/3 of the tongue. Okay. Actually. Loss of vibration and proprioception from the left side of the body. So the body. Okay, that's a hint. Loss of pain sensation from the right posterior 1/3 of the tongue. So pause the video. Again, this question is very simple. The rostral NTS is only referred to as the gustatory nucleus, so it's directly responsible for taste. So just look for the option for taste. Again, loss of loss of pain and temperature sensation from the right posterior one-third of the tongue. That's a function of the glossopharyngeal, and that's general sensations. That's not special sensations. That's not SVA, special visceral afferent. So you exclude it. Loss of taste sensation from the right anterior two-thirds of the tongue. That's correct. Again, it's through the facial nerve. It relates to the NTS. If you have a lesion that affects the rostral NTS, you could end up with partial loss of taste, okay, or complete if it involves it bilaterally, actually. Loss of vibration and proprioception from the left side of the body. That's a function of the dorsal column medial lemniscal pathway. So that spinal cord is not really related to nuclei much. Loss of pain sensation from the right posterior one-third of the tongue. Again, that is a similar option to this one. Again, it's a function of the glossopharyngeal. For the anterior two-thirds, it's a function of the trigeminal in terms of general sensation. And that's it for this question. Now, this is a summary of the nuclei. This is the takeaway you need to have. Motor nuclei are medially placed. So here you see, this is a section of the embryological brainstem. You see, this is the midline. Okay, this is the midline. This will be the fourth ventricle. Okay, somatic motor nuclei are medially placed. Generally, motor nuclei, be it parasympathetic or even motor, they're medially placed. This is opposed to sensory nuclei, which include visceral sensory nuclei and somatic sensory nuclei, which are laterally placed. The sulcus limitans is a groove in the embryo that separates both. So it separates the medially placed motor nuclei from the laterally placed sensory nuclei. So if I have a lesion that affects the medial brainstem, I would expect motor nuclei to be involved. Okay. For example, at the level of the medulla, that would be the hypoglossal nucleus. I would have muscle weakness involving the tongue. At the level of the pons, I would have the abducent nucleus being involved. And hence, I would end up with paralysis of the lateral rectus muscle, okay, and a loss of motor function when it comes to this aspect. So I would be medially deviated and so on. Now, sensory nuclei are lateral. So if I have a lateral pontine lesion, a lateral, medullary lesion, I would expect more sensory involvement. So I don't know, vertigo secondary to vestibulocochlear, nuclear deficits or involvement. Again, this is summary here. Generally, cranial nerve nuclei are located in the tegmentum. So again, we have three major portions of the brainstem. Anteriorly, you have the basilar aspect of the brainstem. You primarily find the corticospinal tract and the corticobulbar tracts descending, so motor tracts. Just posterior to it, you have the tegmentum, which contains the majority of cranial nerve nuclei. Behind the tegmentum, you have the ventricular system. So at the level of the medulla and the pons, that would be the fourth ventricle. At the level of the midbrain, that would be the cerebral aqueduct. Again, you need to know this. So I told you that cranial nerves are numbered in top-down position. This helps you localize the lesion pretty easily. If you have an oculomotor deficit or a trochlear nerve deficit, I would expect the midbrain to be involved. If I have a trigeminal nerve deficit, such as loss of facial sensations or hemianesthesia, whatever, I would expect it to be, I would expect the pons to be involved, or I would expect the lesion to be within the pons. If I have the abducent nerve being involved, I would expect a lesion within the pons. Same applies for the facial, okay, because it arises from the pons, if you remember, just lateral to, the abducent. We also have the vestibulocochlear, which is most lateral in position. So if I have a lateral pontine syndrome, I would expect, vertigo and even potentially hearing loss. Same applies for the medulla. You have the cranial nerves, glossopharyngeal, the nuclei actually of the glossopharyngeal, the vagus, and the hypoglossal, and that's very important. So just know, at the level of the midbrain, you have two cranial nerves, third and fourth. The first two that we're concerned with. At the level of the pons, you have the trigeminal, the abducent, okay, the facial, and the vestibulocochlear. Okay. At the level of the medulla, primarily you have the glossopharyngeal vagus and hypoglossal nuclei that will produce the clinical deficits. And that's it for this section. Again, this is just to make things very clear. And yeah, now we proceed to this question. Yeah, I discussed this actually. A lesion affecting the parasympathetic nucleus of the oculomotor nerve, so parasympathetic function of the third cranial nerve, would most likely result in which of the following clinical findings? Would it be pupillary dilation, pupillary constriction, is it ptosis, or loss of lateral eye movement? So, the parasympathetic nucleus of the oculomotor nerve is referred to as the Edinger-Westphal nucleus, and it supplies it with the GVE fibers to ultimately innervate the sphincter pupillae muscle. So let me show you this more clearly. This would be the pupil, okay? You would have the sphincter pupillae muscle surrounding the pupil. Once you have firing of the parasympathetic nucleus of the oculomotor nerve, you would have pupillary constriction, so meiosis. If you have loss of function, so a lesion affecting the parasympathetic nucleus, meaning you have unopposed pupillary dilation, because pupillary constriction function is lost, the sphincter pupillary muscle is non-functional, you would end up with pupillary dilation, so this would be A, okay? Pupillary constriction is wrong because it's a function of the oculomotor nerve itself, and this is a lesion affecting the oculomotor nerve. Ptosis, yes, you would have ptosis if the oculomotor nerve is involved, because remember, the oculomotor supplies the LPS, the levator palpebrae superioris, which is responsible for elevating the eyelid, but they specifically said the parasympathetic nucleus, or the Eddington-Westphal nucleus. Loss of lateral eye movement, this refers to the lateral rectus muscle, which is again LR6, supplied by the abducens nerve, responsible for eye abduction. So it's not really affected in this case. It would be actually a somatomotor nucleus. So that's it for this question. Yeah. Now I'll proceed to the next slide. So before talking about the cross sections, I'll be reviewing the spinal tracts. Okay, that's a very important thing, even in the brainstem. Yeah, let's take a break. Why not? Okay, now we're proceeding to talk about the spinal tracts. Again, this is a review before proceeding into cross sections. This is very important because as the tracts ascend through the brainstem or descend, be it motor or sensory, they have different appearances. They decussate at particular points you need to be aware about. And most importantly, you need to know the functions of each. We have three major spinal tracts. What is a tract? Again, by definition, it's a collection of nerve fibers within the central nervous system, be it brain or spinal cord. They're typically functionally specialized, okay? So for spinal tracts, I'll start with the spinothalamic tract. Again, this is responsible for pain and temperature, okay, from the contralateral body. So spinothalamic tract, pain and temperature from the contralateral body. It gets into the spinal cord, synapses immediately within the dorsal gray horn, and then decussates. What does decussation mean? Deca is the Roman numeral X. So this is for, where the word decussate comes from. It's a crossing pattern. So the spinothalamic tract would decussate, cross the midline through the anterior white commissure, then ascend within the anterolateral aspect of the spinal cord superiorly. It continues to ascend, and then it reaches the thalamus and goes to the primary somatosensory cortex, where you can process the pain and temperature. So if I have a lesion that affects the spinothalamic tract within the lateral brainstem, I would expect contralateral loss of body pain and temperature. Okay, this is the first tract. The second would be the dorsal column medial lemniscal pathway. Dorsal column, okay, because it's occupied by the dorsal column, or the posterior aspect of the spinal cord, and medial lemniscal, you have a small collection of fibers within the brainstem, within the midbrain, pons, and medulla, that ascends, and it changes shape as you see the cross sections. But in terms of the pathway, and in terms of function, actually, it's responsible for three things you need to be very, careful about. 2-point discrimination, vibration, and conscious proprioception, okay? So, we have the dorsal column, it starts, okay? You have two fasciculi here. It ascends through the dorsal aspect of the spinal cord and reaches the dorsal column nuclei. I talked about this previously, if you recall. The dorsal column nuclei are the nucleus gracilis and nucleus cuneatus, and they form backward protrusions at the level of the brainstem, if you remember from the dorsal view. And this is where the synapse happens. You have the second order neurons, they originate here, and then the tract would decussate, the DCML would decussate, would cross the midline, and would ascend on the opposite side, the contralateral side, as the medial lemniscus. So this string, okay, after the decussation, would be referred to as the medial lemniscus. If I damage this string, I would have contralateral loss of body, 2-point discrimination, vibration, and conscious proprioception. When I say body, I'm referring to the upper limb and the lower limb, primarily. Okay, now two sensory tracts, and you have a single motor tract. Actually, the main motor tract would be the corticospinal tract, corticospinal. Again, this is the upper motor neuron that supplies the anterior gray horn cells with, innervation. If I have a lesion that affects the corticospinal tract, I would have upper motor neuron signs like, positive Babinski sign, like hyperreflexia, hypertonia, and so on. So very simply, start from the primary motor cortex, descends downwards and decussates. It crosses the midline at the level of the spinomedullary junction or the caudal most medulla. You need to know this, the decussation point of the function, okay? It crosses the midline at the spinomedullary junction and descends on the opposite side as the lateral corticospinal tract to supply the lower motor neurons within the anterior gray horn cell, and the lower motor neurons connect directly to the skeletal muscle. So that's the idea. So in the brainstem, especially above the spinomedullary junction. So in the midbrain, the pons, even the upper medulla. If I have a lesion that affects, let me draw this to make it very clear because this is a recurring theme. Okay, I damage this structure. Okay, I would have contralateral spastic paralysis or contralateral spastic hemiparesis, which is muscle weakness. Paresis equals weakness. Plegia equals complete paralysis. So contralateral to the site of the lesion. That's the idea here. So again, we'll proceed to the next slide. We start with the spinomedullary junction, SM, spinomedullary, so the junction between the medulla and the spinal cord. The major events that happens here is the pyramidal decussation, or the decussation of the corticospinal tract, as we said previously. Again, we're taking a section at A, okay? The pyramidal decussation is also referred to as the great motor decussation, or the decussation of the corticospinal tract. Again, it's very ventral in position. If you remember the pyramids that lie within the medulla, at the lowermost aspect, or the caudalmost aspect of the medulla, you have the decussation of the pyramid. So you see fibers that are crossing the midline and descending on the contralateral side as the corticospinal tract, the lateral corticospinal tract. Now, if you look at this section, we see anteriorly the spinothalamic tracts. They always, even if you compare this to the spinal cord, they sit within the anterolateral aspect of the spinal cord. Again, they carry pain and temperature from the contralateral body. So in this case, if I damage the lateral caudal medulla, I would expect contralateral loss of body pain and temperature. Now we also have anterior and posterior spinocerebellar tracts. So these two, half circles, you could say, they feed into the cerebellum, and they're really important because if you have damage to these laterally placed structures, you would end up with ipsilateral ataxia. Okay, meaning same-sided relative to the lesion, and ataxia is muscle discoordination. The cerebellum primarily functions to correct movement in real time. So if you have damage to either the cerebellum or the tracts feeding into the cerebellum, or going away from the cerebellum, you would end up with ataxia. Finally, this is very important. Within the lateral medulla, we start to see the spinal trigeminal nucleus. So that's the spinal trigeminal nucleus, which I explained previously here. If you see, that would be the spinal trigeminal nucleus. Okay, this is it. Actually, it's actually very large. It's extensive. It spans the whole medulla and even the pons up to the upper pons. So if you have a lesion that affects the lateral medulla or the lateral pons, you will have a loss of pain and temperature from the ipsilateral face, or same side of face. We continue again. So sorry. Yeah, you have the spinal trigeminal nucleus, ipsilateral pain plus temperature from the face. You need to know this. When it comes to the dorsal aspect, we see the dorsal column, the continuation of the dorsal column. You have two parts to the dorsal column: the medially placed fasciculus gracilis and the laterally placed fasciculus cuneatus. And you have corresponding nuclei. You have the nucleus gracilis and nucleus cuneatus, from which the second order neurons originate then cross the midline and become the medial lemniscus, as we discussed previously. Again, fasciculus gracilis medial, fasciculus cuneatus lateral, synapse at dorsal column nuclei. So if you notice here, you have the nucleus gracilis and nucleus cuneatus. The fasciculus gracilis terminates at the nucleus gracilis, and the fasciculus cuneatus terminates at the nucleus cuneatus. And then the tract would decussate. Again, this is the DCML pathway. The major thing I want you to remember at this section would be pyramidal decussation, or the gray motor decussation, decussation of the corticospinal tract, the main motor tract. Again, ventral most aspect. Now we proceed to an upper section of the medulla, okay? So we're cutting it B. This is the section of the medial lemniscus decussation, or the decussation of the medial lemniscus. If you see ventrally, we start to see the pyramids, which are, again, they contain fibers of the corticospinal tract that did not decussate yet. So this is above the decussation point, which this is the decussation point, A, B, now we are at B. So this is the site of the decussation of the DCML pathway. So, the dorsal column medial lemniscal tract decussates at the level of the caudal medulla above the level of the spinomedullary junction. So you have the gray motor decussation, the pyramidal decussation, and above it, you have the, the decussation of the medial lemniscus, or the great sensory decussation. So it's an upper level. That's the point I'm trying to like convey. Again, dorsal column fasciculi are no longer apparent. They're not as apparent. You see the nuclei in a greater degree because you see, you remember the gracile tubercle and the cuneate tubercles, these two bulges that are formed by the cell bodies, the nuclei. And they sit in the dorsal position. Again, we have the same structures we see. We have the spinal trigeminal nucleus within the lateral aspect. We have the spinothalamic tracts within the anterolateral aspect. And we have the anterior and posterior spinocerebellar tracts. Same idea. Now, what I want you to take from this is that we start to see a very important structure that will come, multiple times as we see the cross sections. It's referred to as the medial longitudinal fasciculus. Medial because it's very medial in position, okay, which makes sense. Longitudinal because it runs longitudinally in the brainstem throughout the whole brainstem, actually, midbrain, pons, and medulla, and it functions to coordinate head-eye movement. How? The MLF connects the nuclei of the third, fourth, and sixth cranial nerves, which are responsible for extraocular muscle control, to the vestibular nucleus. And this is very important because this allows you to adjust eye movement to head movement. Let's say you see a bird that is zipping through your visual field and you want to focus at it, okay? The ability to adjust your eye movement to your head movement, this is a reflex, by the way, is through the MLF. What I want you to remember is that the medial longitudinal fasciculus is, it actually degenerates in multiple sclerosis. It's just a factoid you need to know. You'll discuss it more in pathology, but I saw a couple of questions about it. So MLF degeneration, if you see multiple sclerosis in the question, the answer will always be MLF for the midterm at least, because it's brainstem only. That's it for the MLF. Then you have the inferior olivary nucleus. This baggy structure you're starting to see it, okay? It's a gray matter mass, so it's a nucleus actually, and it corresponds to the olive, if you remember. The inferior olivary nucleus is a very baggy structure that produces the ventrally placed olives, just lateral to the pyramids and lateral to the hypoglossal nerve. Now, it's partly seen. You'll see it better at upper sections. And that's it for this section. We start to see a part of the nucleus ambiguous, okay, which again is the branchiomotor nucleus at the level of the medulla, if you remember, supplying the vagus and the glossopharyngeal, so that you can ultimately innervate the muscles of the pharynx and the larynx involved in swallowing and phonation or production of voice or sound. So essentially talking. And yeah, that's it for this section. We move to this section. This is the most important section when it comes to the medulla. This is very, very important. Okay, you'll probably get a question about this. The structures here are very important. Now, when it comes to the histological sections, it looks scary. However, there is a general rule we can follow to make things much simpler than usual. When you see black color or dark staining color, this is indicative of tracts or myelinated axons. I said that a tract is a collection of nerve fibers or axons that are either traveling upwards or downwards or connecting some structures. Okay. The white color, on the other hand, or the pale, unstained grayish color represents nuclei or cell bodies. So if you look here, this would be the hypoglossal nucleus, okay, which is very medial in position. Okay, it looks pale grayish compared to the other structures here, which will look black. They correspond to tracts. Same applies again. This is a very nice rule you can use because again, the stains typically stain myelin. Okay, they bind myelin. Okay, so if you have myelinated axons as in tracts, it would look dark or black or staining. Again, the defining feature of the upper medulla or the rostral medulla would be the inferior olivary nucleus. You see this baggy structure, this extensive structure. Again, it's a collection of cell bodies. You don't need to know its function, but it's a collection of cell bodies within the ventral aspect of the medulla. So this is ventral or anterior. Okay, this is dorsal. You see the fourth ventricle. Dorsally, you have the fourth ventricle, which connects inferiorly to the central canal. If you remember your basic lecture. So the inferior olivary nucleus, if you see it very clearly, with its full glory, you think about the rostral medulla, the upper section of the medulla. Now, when it comes to the structures, I'll start from the ventral aspect, okay, or the anterior aspect. You have the pyramids, which again correspond internally to the corticospinal tract, or the corticospinal fibers that are descending to eventually cross the midline and become the lateral corticospinal tract on the opposite side. So the fibers here would control voluntary movement on the opposite side of the body, okay? Just dorsal to it, you have a bundle of fibers that corresponds to the dorsal column. It's referred to as the medial lemniscus. The medial lemniscus, again, is a part of The dorsal column, think 2-point discrimination, vibration, and conscious proprioception. Same thing here. It's identical. It carries it from the opposite side of the body, so upper limb and lower limb. If you move backwards, you see, a collection of nerve fibers. It's very minute. It's very tiny. That's the MLF, the medial longitudinal fasciculus. I talked about its function. It coordinates head and eye movement. It adjusts eye movement to head movement. If it degenerates, it's MS. It's multiple sclerosis. Now we start to talk about the nuclei, which is, the most important part here. Most medial in position, as we discussed previously, is the somatomotor column, or the GSE column. So that's the hypoglossal nucleus, things supplied to intrinsic tongue muscles responsible for tongue movement, GSE. Okay? Just lateral to it, we have the parasympathetic nuclear column, if you remember. So here at the level of the medulla, we have the dorsal vagal nucleus, or the dorsal motor nucleus of the vagus, which supplies the thoraco-abdominal viscera through the vagus nerve up to 2/3 of the transverse colon. So the hypoglossal nerve, the hypoglossal nucleus, most medially, and the dorsal motor nucleus of the vagus. Okay. Then just lateral to it, we see the nucleus tractus solitarius. Now, and I remember this structure as being, a black island in a white sea, because you have the nucleus tractus solitarius and the solitary tract. Okay. It lies lateral to the dorsal motor nucleus of the vagus. So, if you notice, you have the fourth ventricle here. Anterior to it, we have the majority of the nuclei, because again, they're pale staining, or the grayish in color. So hypoglossal nucleus, then we have the dorsal vagal nucleus, then we have the nucleus tractus solitarius. I told you the most lateral gray matter column at the level of the sensory nuclei would be, the vestibulocochlear nuclei. So if I have damage to the lateral most medulla, I would expect vertigo and even potentially, hearing loss. Okay, because again, that's the vestibular nuclei. It would connect immediately to the vestibulocochlear nerve, and it's important for vestibular input. So again, we talk about the dorsal motor nucleus, the MTS, the vestibular nuclei. That's a very important nucleus, the nucleus ambiguus. Know that it sits within the lateral medulla. It sits within lateral medulla. Okay, it's laterally in position within the reticular formation. And I told you, in terms of function, it's motor supply to the muscles of the pharynx and the larynx. So if I have a lesion that affects the lateral medulla, okay, I would expect dysphagia and dysarthria. Dysphagia and dysarthria, because it supplies the vagus nerve with the branchial efferents it requires to, mediate swallowing and phonation. So, so if I have, medullary lesions, I would expect damage to the pyramid, so the corticospinal tract, contralateral spastic paresis, the medial lemniscus, contralateral loss of 2-point discrimination, vibration, and conscious proprioception. Why? Because we lie above the decussation point, above the crossing point. Posterior to it with the MLF, it will present as nystagmus classically. And if you have, of course, the hypoglossal nucleus, the distinguishing feature when it comes to medial lesions, medial medullary lesions, would be the hypoglossal nucleus. Because you would have ipsilateral tongue deviation, because this nucleus contains the cell bodies that ultimately supply the intrinsic tongue muscles. So that's an important point. You have 4 medial structures that you need to be very aware of. You have the nucleus ambiguus, which corresponds to dysphagia and dysarthria. If you see dysphagia and dysarthria in a question, it's almost always nucleus ambiguus. Okay. You have also the spinothalamic tract, the spinal trigeminal nucleus plus tract. Again, I talked about the spinal trigeminal nucleus. It's a part of the 3 trigeminal nuclei. The spinal trigeminal nucleus is responsible for ipsilateral, facial pain and temperature. Okay, so if I lesion the lateral medulla, okay, this is actually the spinal trigeminal nucleus, by the way. This gray matter structure within the lateral medulla. I would expect ipsilateral loss of pain and temperature from the face. Okay. Of course, we have a large patch of dark fibers that connects the medulla to the cerebellum, most laterally in position actually. It's called the inferior cerebellar peduncle. As I said previously, if you have damage to the input to the cerebellum or damage to the output from the cerebellum, you'd end up with cerebellar signs, which include ataxia and dysmetria. Ataxia is simply jerky, uncoordinated movement, okay? And dysmetria is where you overshoot or undershoot. So let's say I have a water bottle here. Okay, I want to grasp it accurately. The ability to grasp it accurately is a function of the cerebellum. If I overshoot or undershoot, that's dysmetria, and this is indicative of either, a lesion that affects the ICP, the inferior cerebellar peduncle, one of the peduncles, or the cerebellum itself. Again, connects the medulla to the cerebellum. That's it for the rostral medulla. Now we get to blood supply. This is a very nice slide I wanted to include it shows the blood supply to the medulla, and it corresponds to the lesions, actually, which we'll discuss in detail later on. The medial medulla is supplied through the anterior spinal artery. So this is very important. You need to know this. This is memorization. The anterior spinal artery supplies the medial medulla, corresponding to the corticospinal tract, the medial lemniscus, the MLF, the medial longitudinal fasciculus, and the hypoglossal nucleus. So if I have occlusion of the anterior spinal artery, I would expect contralateral spastic paralysis. I would expect contralateral loss of two-point discrimination, vibration, and conscious proprioception. I would expect nystagmus and ipsilateral tongue deviation, secondary to same-sided tongue muscle dysfunction. Because you have two sides of the tongue, obviously, and both hypoglossal nerves supply it. If you have a right-sided hypoglossal nucleus lesion, the right-sided muscles become weak. So you have unopposed action of the left-sided muscles, and they push the tongue towards the side of the lesion. So ipsilateral. So this way, for example. Again, you have the structures labeled here if you want to get a better idea. Hypoglossal nucleus, NTS. You have the dorsal vagal nucleus here. You have the vestibular nuclei corresponding to vertigo if it's lesioned. We have the inferior cerebral peduncle corresponding to ipsilateral same-sided ataxia or dysmetria. We have the spinal trigeminal nucleus here, which will correspond to ipsilateral loss of face pain and temperature. The nucleus ambiguous, the most important structure in my opinion is the lateral medulla, because it helps you differentiate lateral medullary lesions from medial medullary lesions, dysphagia, dysarthria, as we said. And within the anterolateral aspect of the rostral medulla, we have the spinothalamic tract. Same position if you compare it to the previous sections, by the way. You would have contralateral loss of body pain and temperature. Okay, and that's it for the various manifestations. Again, most important, dysphagia and dysarthria. In terms of blood supply, medial medulla, anterior spinal artery, and lateral medulla. So this whole portion, including all the structures we mentioned, is referred to as pica, the posterior inferior cerebellar artery. Now, that's a very important point. You need to know this. Now we proceed to the caudal pons. Again, this is the lowest section of the pons. Now, the pons can be divided broadly to help you understand into the basilar part and the tegmental part. The basilar part sits on the base of the skull and has the name basilar. So basilar part equals ventral. Like ventralmost pons equals basilar part, or basis pontus. You have a million names, but the ventralmost aspect or the anteriormost aspect of the pons is the basilar part. It remains mostly unchanged between the upper and lower sections. You have three major structures that are contained within the basilar pons, okay? You have the corticospinal fibers, that are descending through the ventral brainstem to get to the spinal cord. You have the corticonuclear fibers, okay, which is very important. It supplies the cranial nerve motor nuclei. So it's similar to like the corticospinal tract, but think about, cranial nerve motor nuclei. And we have the pontine nuclei in between. These dots represent the pontine nuclei. Again, they correspond to a pathway that you don't need to know much about, but just know that the transverse pontine fibers, which again give this striated appearance, look, transverse pontine fibers, it gives this striated appearance to the basilar pons. They arise from the pontine nuclei and they go to the opposite cerebellar hemisphere through the middle cerebellar peduncle. So it's very important. If I have a lesion that affects the basilar pons, what will happen? Okay, it depends. Is it ipsilateral? Is it unilateral or one-sided, or is it bilateral? If you have bilateral involvement, then all corticospinal input going to the spinal cord is gone, and hence you would have quadriplegia. If it's one-sided or unilateral, you would expect contralateral spastic paralysis. Same thing. You have the trapezoid body here in the middle. It corresponds to the cochlear pathway. So you have fibers that cross the midbrain at the level of the pons, corresponding to the cochlear pathway or the hearing pathway, the hearing system. On either side, we have the medial lemniscus. Again, the medial lemniscus goes from being vertically placed to, this way to being horizontally placed at the level of the pons, but still it's medial in position. Now, the most important thing in this slide is the nuclei that arise from the caudal pons, okay? This includes, the nucleus of the abducent nerve or the motor nucleus of the abducent nerve and the motor facial or the facial motor nucleus. Now, what is the facial colliculus? This is the caudal pons or the level of the facial colliculus. The facial colliculus is a little hill that you find when you look at the pons from the posterior aspect, and it corresponds to the facial nerve looping around the abducent nucleus. So it loops. So this is the facial nucleus or the facial motor nucleus, and it loops around the medially placed abducent nucleus to exit the basilar pons through the basilar part. So if I have a lesion again that affects the basilar pons completely, okay, I would expect abducent nerve deficits and facial nerve deficits, because the fascicles of both nerves exit the ventral part of the brainstem, or the ventral part of the basilar pons. Again, so abducent nucleus, medial most, GSE in terms of function, again, somatomotor, facial motor nucleus, branchiomotor nucleus is responsible for supply to the muscles of facial expression. I talked about this facial colliculus. Lateral most, you see the middle cerebellar peduncles, which connect the pons to the cerebellum. This is very important because, again, if you have a lateral pontine lesion, you'd expect ipsilateral ataxia or cerebellar signs, because, again, the input going to the cerebellum is impaired, and hence you would have ataxia. Now, this is an important clinical correlation. We'll discuss this in detail later on. Locked-in syndrome. What is locked-in syndrome? Most important thing is a patient with locked-in syndrome presents to the clinic with quadriplegia, meaning paralysis of all four limbs, upper and lower, both. How typically the case scenario will get, and it will always be on the exam, he will get you this, okay? This would be a patient presents to the clinic, he's an alcoholic. You see hyponatremia, so low sodium levels in the blood, and the physician corrects the hyponatremia too quickly. So we have inappropriate correction of hyponatremia too quickly. This will cause a massive rise in plasma osmolarity. So you would have water going out, going outside the corticospinal fibers and the corticonuclear fibers, and you would have demyelination. This will lead to osmotic demyelination of the corticospinal tract, corticobulbar tract, and the two, fascicles that arise from the basilar part. And the patient will present with quadriplegia, most importantly, and the only thing he maintains is vertical gaze. That's it. Okay, he's aware sensory-wise. However, in terms of motor planning and swallowing or whatnot, motor functions of the head and neck, motor functions of the body, it's completely gone. This is very important. So rapid correction of hyponatremia leads to locked-in syndrome, where the basilar pons is involved bilaterally. That's it for the caudal pons. Let me just drink some water. Now, this is a histological section of the pons. Same section, the level of the facial colliculus, which is very important. We see the facial colliculus posteriorly, which is formed by the abducent nerve looping around the facial nerve looping around the abducent nucleus. This is the basilar pons. How do I know? You have descending corticospinal and corticonuclear bundles. So if you see this appearance within the basilar aspect, you think it's corticospinal, corticonuclear, and this is the pons. Also, we see some striations which correspond to the transverse pontine fibers. If you go back to the previous image, transverse pontine fibers going laterally to get to the middle cerebellar peduncles. If you see this striated appearance, this is the pons. We see the ventricular system, the fourth ventricle, corresponds to either the medulla or the pons. And again, this is a diagrammatic representation of the facial nucleus, or the facial fascicle actually looping around the abducent nucleus, producing a bump posteriorly. In terms of labeling, one would be basis pontus, or the basilar pons containing corticospinal corticonuclear fibers. Two would be the interspersed pontine nuclei, from which transverse pontine fibers arise, going to the middle cerebellar peduncle. So same thing here. They're represented by dots here. So dots, dots, dots. Three would be the abducent nucleus actually. Again, it's medial in position. It's somatomotor in function. 4, this pale grayish structure would be the facial motor nucleus. Again, cell bodies or nuclei are gray or pale in comparison to the tracts or the fibers. So you have the facial fascicle. It loops. This dark thing is actually the facial nerve or the facial fascicle. It loops around the abducent nerve, producing the facial colliculus, and arises lateral in position. So look how it arises lateral in position. So if I have a medial pontine syndrome, I would have classically abducent nerve deficits. If I have a lateral pontine syndrome, I would have facial motor nuclear deficits. So again, 3 would be the abducent nucleus, 4 would be the facial motor nucleus, 7 would be the middle cerebellar peduncle, this large dark patch of fibers that are going to the cerebellum. And yeah, this includes the most important structures. Again, 6, this triangular collection of fibers is the MLF. Remember, the MLF is always medial in position. Okay. And yeah, that's it for this. These structures. Again, 5 would be the medial lemniscus. Again, it's horizontal in position in this case, if you notice, as opposed to being vertical. So that's the idea for this section. Now we move to the rostral pons, the level of the trigeminal nuclei. So this is an upper section, the level of the pons. At the lower section, we saw two nuclei, the abducent and the facial. Now we see, the trigeminal nuclei, namely the trigeminal motor nucleus, which is medially placed, and the principal sensory nucleus, or the chief sensory nucleus of the trigeminal nerve, responsible for ipsilateral, two-point discrimination, vibration, and conscious proprioception. Okay. So the trigeminal motor nucleus, as you said, is medial in position. Motor nuclei are generally medial to, sensory nuclei. That's a rule you can get. If I damage this trigeminal motor nucleus, I would end up with, paralysis of the muscles of mastication. Okay, because it's motor to the muscles of mastication. If I have damage to the principal sensory nucleus, I would end up with, loss of ipsilateral two-point discrimination, vibration, and conscious proprioception from the face. Okay. Now, again, basal pons does not change much. You have descending corticospinal, corticonuclear fibers. Okay. When it comes to the spinal lemniscus is simply a continuation of the spinothalamic tract. That's it. So it's ascending through the brainstem. Once it reaches the upper pons, it's referred to as the spinal lemniscus. That's simple. There's nothing new here. Again, you have the trapezoid body in the center. It's a crossing of the cochlear pathway. You have the medial lemniscus on either side. You have the MLF, which is medially placed, unchanging, the fourth ventricle. And yeah, that's it for the level of the trigeminal nuclei. Most importantly, you need to know principal sensory nucleus and, trigeminal motor nucleus, because it's motor to the muscles of mastication involving chewing. We move to the level of the inferior colliculus, the level of the midbrain. Okay, so caudal midbrain, lower section through the midbrain, inferior colliculus. As I told you, you need to know this. The inferior colliculus is responsible for auditory reflexes, okay, or hearing reflexes. Just memorize this, okay? It's posterior in position. I'll start from the posterior aspect and progress anteriorly. Posteriorly, you have the inferior colliculus, which is responsible for auditory reflexes. Anterior to it, you see a tube-like structure. The tube-like structure that connects the third ventricle to the fourth ventricle. And that's the cerebral aqueduct. If you see the cerebral aqueduct, it's always the midbrain, always, okay? This is the lowest section of the midbrain, so you see the trochlear nuclei, as opposed to seeing the oculomotor nuclei. Because again, 3, 4, again, the cranial nerves are numbered in top-down position, so the trochlear nucleus arises from, the lowest section of the midbrain. Again, it's medial most because it belongs to the somatomotor column. Again, remember, it's applied to the superior oblique muscle. Now, the special thing about the trochlear nucleus is that it actually crosses the midline and arises from the dorsal, aspect of the brainstem. So the right trochlear nucleus would supply the left superior oblique muscle. You get it? It's the only, cranial nerve that does this, actually. Again, anteriorly, see the cross cerebri. You have the substantia nigra here. The substantia nigra is gray matter. It's composed of dopaminergic cell bodies, so dopamine-containing cell bodies. It actually degenerates in Parkinson's disease. That's all you need to know for now. Substantia nigra, anterior part of the, of the midbrain, degenerates in Parkinson's disease. Anteriorly, you have the cross cerebri. The cross cerebri, which contain, most importantly, the majority of the cross cerebri contains corticopontine fibers that are descending through the midbrain, the ventral aspect of the midbrain. However, within the middle portion, the middlemost portion of the cross cerebri, we have the corticospinal, corticonuclear fibers. And this is very important because it would correspond to the lesion. If I have a medial cerebral peduncle lesion, so let's say, involving this whole thing, okay, I would expect, contralateral spastic paralysis that results from damage to the corticospinal fibers that are descending through the ventral part of the midbrain. Again, this is the cross cerebri, okay? This is the tegmentum. Cross cerebri plus tegmentum equals cerebral peduncles, which are the stalk-like structures that connect the lower brainstem to the forebrain. And anteriorly and medially in position, you have the MLF, nonetheless. Now, we have a very important structure here. This is the decussation of the superior cerebellar peduncle. The superior cerebellar peduncle sends out fibers that cross the midline, the level of the lower, midbrain, and they go back to the cortex to give it information on how to better correct movement. So the cerebellum would come up with the perfect motor plan and send it back to the, cortex, to have the perfect plan in order. Okay. Now these structures, again, lateral to medial, this is not really high yield. ML, medial lemniscus, contralateral, two-point discrimination, vibration, and conscious proprioception. You have the spinal lemniscus, which are, it's a continuation of the spinothalamic tract. So if you have damage to the spinal lemniscus, you would have contralateral loss of, pain and temperature. And for the trigeminal lemniscus, you see the trigeminal nuclei, the 3 trigeminal nuclei, principal sensory nucleus, spinal trigeminal nucleus. They all send fibers that ascend and they get grouped together as the trigeminal lemniscus. So it's responsible for facial sensations. Okay? And then finally, we have the lateral lemniscus. It's a part of the cochlea or the auditory pathway. As the name implies, the most lateral in position. So it's this way here. And it corresponds to the inferior colliculus. You don't really need to know much about it. Just know lateral lemniscus equals cochlear function or hearing function. And that's it for this section. Again, this is from the doctor's slides. Same thing, black equals tracts, and pale grayish or white stuff equals nuclei. Here, this middlemost portion would be the superior cerebellar peduncle decussation. You would have the trochlear nuclei here on either side. Again, the trochlear nerve actually arises from the dorsal brainstem. The cross cerebri is a white matter bundle anteriorly. In the middle, in this portion, you would have the descending corticospinal corticonuclear fibers that supply the spinal cord and the cranial nerve motor nuclei. This butterfly-shaped gray structure is the substantia nigra because, again, it's cell bodies. Dopamine-containing cell bodies degenerates in Parkinson's disease. And that's it for this section. Again, level of the inferior colliculus, you see 2 bulges posteriorly corresponding to auditory reflexes. This is the center for auditory reflexes. And yeah, that's it for this part, for the inferior colliculus. Now we move to the rostral midbrain, so level of the superior colliculus. You have the superior colliculus and the inferior colliculus. The superior colliculus is involved in visual reflexes, so that's critical. The most important thing in this section would be the oculomotor nuclear complex. We have 2 nuclei that supply the oculomotor nerve with fibers. Medially placed, somatomotor oculomotor nucleus, so that you can supply all extraocular muscles of the eye except for LR6-SO4. And laterally placed, you have the Edinger-Westphal nucleus. Okay, the Edinger-Westphal nucleus is the parasympathetic nucleus of the oculomotor nerve. So GVE, it corresponds in terms of function to pupillary constriction and accommodation. For the oculomotor nucleus, which is GSE, or the main nucleus of the oculomotor nerve, it sends out GSE fibers, general somatic efferent fibers, to the extraocular muscles. Again, medial in position, relatively speaking. You still see the MLF here, which is medial and anterior in position. Now, the major structure I want you to keep in mind when it comes to this section, level of the the superior colliculus, would be the red nucleus. The spherical structures which are located within the tegmentum, actually. If you lesion the red nucleus, you would have contralateral involuntary movements. This is all you need to know. The red nucleus is typically involved in, modifying voluntary movement and making sure everything's right when it comes to voluntary movement. If you damage the red nucleus, you would have contralateral involuntary, movements, including tremors, even chorea. Chorea is Latin for dancing. So a lesion of the red nucleus would precipitate involuntary movements, i.e. tremors. On the opposite side, just know this by heart. Again, we still see the substantia nigra, the cross cerebri. We see the mesocephalic nucleus, which is trigeminal because it corresponds to the midbrain, obviously. We see the same bundle apart from the lateral lemniscus because, the lateral lemniscus actually terminated at the level of the inferior colliculus, but that's not really important to know. And again, most importantly, red nucleus lesion, contralateral involuntary movement, or simply a tremors. Now, this is a histological section of the same level, the rostral midbrain at the level of the superior colliculi. 5 would be the superior colliculus. Again, visual reflexes. Now, for 1, that would be the oculomotor nuclear complex, which is composed of 2 nuclei. The Edinger-Westphal nucleus, which is, again, GVE or parasympathetic, and the medially placed, main nucleus of the oculomotor nerve, think GSE supply or general somatic efferent supply to the extraocular muscles. 2 would be this, pale, unstained structure, which is indicative of it being gray matter, and it's the red nucleus, as the name implies. It's responsible for controlling or modifying voluntary movement on the opposite side of the body. If I have a lesion here, I would end up with contralateral involuntary movement, i.e. tremors. 3 would be the substantia nigra, again, gray matter, as a part of the cross cerebri. And 4, this is very important. What is 4? Think about it. So we have a cranial nerve that arises from between the 2 cerebral peduncles. this region is referred to as the interpeduncular fossa. So at the upper level of the midbrain, the oculomotor nerve would arise from within. Okay, so that's the fascicle of the oculomotor nerve. That's very important because if I lesion this part, if I damage this whole section, let's say this section, okay, I would expect for starters, because the crus cerebri is involved and the middle portion of the crus cerebri is involved, I would expect, contralateral spastic paralysis, one. And because the oculomotor fascicle is involved, I would expect, oculomotor palsy. I would expect the pupil to be, dilated, so unopposed pupillary dilation, and so on. Again, same section, but this is a good diagram. Now, again, this is a review slide outlining all the major sections, medulla, pons, and midbrain. You need to focus on the defining features. For the medulla, that would be the inferior olivary nucleus. This baggy structure, again, gray matter structure. It looks pale. For the pons, that would be the middle cerebellar peduncle because it's very large. It's the largest out of the peduncles. And it connects the pons to the cerebellum. You also have the striated appearance, which corresponds to the transverse pontine fibers. Anteriorly, within the basal pons, you have the corticospinal and the corticonuclear, fibers that are descending downward. It has a very unique appearance because it's bundled. It's actually, spread out due to the passage of the transverse pontine fibers. And for the midbrain, how do I know it's the midbrain? Well, I simply see the cerebral aqueduct. Okay, the cerebral aqueduct. This is the level of the superior colliculus, the substantia nigra, the gray matter structure, which contains dopamine cell bodies or dopaminergic cell bodies, and it corresponds to Parkinson's disease. So that's another important thing. You have the crus cerebri here, the middlemost aspect, which correspond to the corticospinal, the corticonuclear fibers that are descending. If I lesion this part, contralateral spastic paralysis. And yeah, that's the point. That's the review. Now we move to the parasympathetic nuclei or ganglia. So this is just memorization. You just need to know which parasympathetic nuclei correspond to which ganglia in the head and neck region, and which structures do they supply. So we have 4 parasympathetic, nuclei at the level of the brainstem. Most superiorly, you have the Edinger-Westphal nucleus, okay, which supplies the oculomotor nerve, which mediates, pupillary constriction. You need to know, again, generally, the autonomic nervous system is composed of a preganglionic neuron and a postganglionic neuron, right? The preganglionic neuron would be the oculomotor nerve, okay, or it would actually contain GVE fibers that synapse onto the ciliary ganglion. From the ciliary ganglion, you have short ciliary nerves that innervate the sphincter pupillae muscle, leading to pupillary constriction. Okay, so cranial nerve 3, Edinger-Westphal nucleus, corresponds to the ciliary ganglion, which supplies the sphincter pupillae and the ciliary muscle. Okay, so they will ask you about this definitely. What nucleus is associated with the ciliary ganglion? It would be the Edinger-Westphal nucleus. Now we move on to the the second pair of nuclei. We have the superior and inferior salivatory nuclei. The superior salivatory nucleus supplies the facial nerve, okay? And it synapses at 2 parasympathetic ganglia within the head and neck region. We have the pterygopalatine ganglia, or the ganglion, which actually supplies the lacrimal gland, is responsible for tear production or lacrimation. So if I have damage to the superior salivatory nucleus, I would expect loss of preganglionic supply to the pterygopalatine ganglion, and has decreased tear production, so dry eyes. Same applies for the other ganglion. The superior salivatory nucleus supplies the facial nerve with the fibers it requires to synapse at the submandibular ganglion and supply it to submandibular and sublingual glands. So cranial nerve 7, superior salivatory nucleus, pterygopalatine plus submandibular ganglia, which mediates the functions of lacrimation and salivary secretion. Yeah, that's important. Now, finally, and the most important, it's not really that important, but the inferior salivatory nucleus corresponds to the auditory ganglion. It supplies the glossopharyngeal nerve. So it's the parasympathetic nucleus of the glossopharyngeal, because the glossopharyngeal supplies the parotid gland. So preganglionic parasympathetic fibers synapse at the auditory ganglion, very close to the parotid gland. And you have postganglionic fibers to mediate salivary secretion from the parotid. So that is the idea here. You need to memorize again what you need to know: which nucleus is associated with which parasympathetic ganglion. You have 4 parasympathetic nuclei and 4 parasympathetic ganglia. Okay, you need to know which is associated with which and which is associated with which function. Yeah, that's it for this part. Again, now we'll be discussing, the cranial nerve lesions. This is very important. So, okay, now we proceed to talk about the various cranial nerves individually and their associated lesions. Okay, so this section will always talk about the palsy or the associated lesion. Okay, and you have general properties and review of function here. So I'll be mainly focusing on the palsies because, I revisited this multiple times. Okay, so we start with cranial nerve 3, the oculomotor nerve. It originates from the rostral midbrain, the level of the superior colliculus. It emerges from within the interpeduncular fossa. If you remember, just medial to the cross cerebri or the cerebral peduncles. It contains two types of fibers, GSE or somatomotor and parasympathetic or GVE. Same thing here in terms of function, LPS supply in all extraocular muscles except for LR6-SO4 and parasympathetics to pupil constrictor and ciliary muscles. For the palsy, this is very important. In oculomotor palsy, you would have the eye deviating down and out. Why? Because all other extraocular muscles, except for the lateral rectus and the superior oblique, they're all paralyzed. So you have unopposed action. You have unopposed actions of the lateral rectus and the superior oblique, and this will lead to the down and out gaze you see here. So if you compare this pupil to this pupil, this is deviating down and out. So for the right eye, that would be the right bottom quadrant. Okay. You would also have complete ptosis. Why? The oculomotor again supplies the levator palpebrae superioris, which is a muscle that elevates the eyelid. So let me draw this. You have a muscle that elevates the eyelid. Okay. If you have loss of supply to the LPS, you would have natural drooping or complete ptosis of the upper eyelid. And that is an important clinical sign. So you would have down and out gaze secondary to unopposed actions of the lateral rectus and superior oblique. In questions, this could be described as lateral strabismus. Strabismus simply means, crossed eye. So the eye would be deviating abnormally secondary to weakness to a particular muscle. So in this case, because the medial rectus is not operating well enough, because you have oculomotor palsy, the lateral rectus will pull on the eyeball very strongly, making it deviate to the side. And this is referred to as lateral strabismus. This will present with diplopia or double vision. So they could describe it to you in a case as having double vision generally, okay, because you have muscle weakness, you have extraocular muscle weakness, and this will precipitate diplopia. Now, you would also have mydriasis or a blown pupil, so unopposed pupillary dilation. I talked about this previously. When you have damage to the parasympathetic fibers or the GVE fibers that supply the sphincter pupillae muscle, you would have unopposed action of the dilator pupillae muscle, which will cause mydriasis or unopposed pupillary dilation. So we have two muscles that are responsible for pupillary narrowing or dilation. We have the sphincter pupillae muscle, okay, and we have the radial muscles, okay. If the input to the sphincter pupillae muscle is lost, you would ultimately have unopposed action of the radial muscle or the dilator pupillae muscle, and it's supplied through sympathetics. So you have unopposed sympathetics to the dilator pupillae muscle, and you would have a blown pupil. So in combination, the eye would be deviated down and out, and also you would have mydriasis or a blown pupil, okay, due to unopposed pupillary dilation. That's it for oculomotor palsy. Again, you typically compare the pupil to the other side, so you see a clear difference in terms of diameter. Yeah. Now for the trochlear nerve. Again, the trochlear nerve is somatomotor to the superior oblique muscle, which causes depression when the eye is adducted. It originates from the caudal midbrain, so think inferior colliculus level. It emerges from the dorsal midbrain, so from the posterior aspect of the brainstem. It's a purely motor nerve. It only contains general somatic efferent fibers. Okay. Again, as I told you, the right trochlear nucleus would supply the left superior oblique, and the left trochlear nucleus would supply, the right superior oblique, because again they loop around and they arise from the dorsal brainstem. For trochlear palsy, the classical clinical picture would be diplopia. When you see diplopia or double vision, you think immediately about the three cranial nerves that supply extraocular muscles, including the oculomotor, the trochlea, and the abducens. Okay, so classically in a case it would be described as double vision that is worsened when you try to read a book or you climb down the stairs. Okay, and the patient would typically tilt his head to the contralateral side to realign the axis. So when you have trochlear palsy, okay? The axis would be pointing this way, okay? You would have contralateral head tilt to compensate artificially. That's not really that important. In the question, all you need to remember is, you can't read a book or you can't travel down the stairs when you have a trochlear nerve palsy. Again, so this is very important. Can't see the floor with cranial 4 damage. So that's a mnemonic. Can't see the floor with cranial 4 damage. Difficulty going down the stairs and reading. And that's it for the trochlear palsy. We move to the abducent. Again, abducent meaning mediating eye abduction. So naturally, if you have a problem with the lateral rectus muscle, you would have unopposed action of the medial rectus muscle, and you would have medial strabismus. So the eye would be deviated medially. It arises from the caudal pons at the level of the facial colliculus. Again, it emerges from the medial most aspect of the pontomedullary junction. Because again, remember, somatomotor nuclei are medial. They're dead midline, okay? Supply to the lateral rectus muscle causes abduction of the eye from the basal pons. So if you have a basal pons lesion, especially when you're talking about the medial aspect, you would expect medial strabismus or abducent nerve deficits. Okay, fibers genosomatically different purely. In palsy, cranial nerve 6 palsy or abducent nerve palsy, you would have medial strabismus where the eye is persistently adducted or medially deviated. If you ask the patient to abduct his eye or look laterally, he would have difficulty doing so. And this is due to unopposed action of the medial rectus. Again, we have the lateral and medial rectus, same thing, same story. You would have unopposed action of one muscle because the other is paralyzed. That's it for abducent palsy. This is a question for you. A patient suffers a stroke in the pons in the blue area, so this region. They told you it's the pons. Even if they didn't tell you, by the way, I can know it's the pons through the large middle cerebellar peduncles that connect the pons to the cerebellum, the fourth ventricle, and this striated appearance within the basal pons representing the transverse pontine fibers that are traveling through the middle cerebellar peduncle to the cerebellum. So again, this is the right side of the image. He will present with which of the following clinical signs? So I see, take a moment. Would it be right-sided spastic paralysis, left eye deviating down and out, right-sided facial paralysis, right eye deviating inwards, or right eye deviating down and out? Okay. So here, when it comes to the fibers that are contained within the basal pons, primarily you have the corticospinal, the corticonuclear fibers, which are descending motor tracts. Okay. So I would expect contralateral spastic paralysis. So this is the right side. So I would expect left-sided spastic hemiparesis or left-sided spastic paralysis. You get it? Also, again, we have two major cranial nerves that arise from the caudal pons. Okay, we have the fascicle of the abducent, which is medial in position. You have the fascicle of the facial nerve, which is lateral in position. So if you notice, the blue region actually cuts through the abducent nerve, and hence you would have abducent nerve deficits. I just discussed this previously. The abducent nerve supplies the lateral rectus muscle, right? So you would have unopposed adduction of the eye. You would have a persistently adducted eye. So the eye would be deviated medially, okay? And it's ipsilateral, okay? So it would be deviated medially. Right-sided spastic paralysis, no, you would have left-sided spastic paralysis because the corticospinal tract decussates at the spinal medullary junction. Left eye deviating down and out, that's oculomotor palsy. Okay, that's the level of the upper midbrain. It's not really here. Right-sided facial paralysis, that's a function of the facial nerve. If you see it's not involved. Right eye deviating inwards, that's the correct option. So you would have left-sided spastic paralysis, and you would have a right-sided medial strabismus or right eye deviating inwards. Right eye deviating down and out, again, that's also oculomotor palsy. So yeah, we proceed. Now, this is a summary slide to outline the cranial nerve nuclei responsible for extraocular muscle control, i.e. eye movement. So for the oculomotor, it supplies all extraocular muscles except for the lateral rectus and the superior oblique. This includes the medial, superior, inferior recti, and the inferior oblique muscle. Signs would be, again, in terms of oculomotor palsy, ophthalmoplegia with the eye turned down and out, and mydriasis. Okay, so the pupil would be blown, unopposed pupillary dilation. You would also have complete ptosis, so drooping of the upper eyelid, because the upper eyelid muscle, the LPS, is paralyzed. So you see, this is the function elevation of the eyelid, oculomotor nucleus, superior palpebral levator. You'd have ptosis, as I said. Again, the parasympathetic fibers that originate from the Eddington-Westphal nucleus supply the sphincter pupillae muscle responsible for pupillary constriction. So you would have mydriasis, you would have a blown pupil. You would also have loss of accommodation, which I'll discuss later on. Mydriasis and loss of accommodation. Again, accommodation is where the lens becomes more convex to accommodate for near vision. You want to focus your gaze at a closely placed object. That's a function of the parasympathetic fibers or the GVE fibers stemming from the Eddington-Westphal nucleus. Trochlea, very simple, supplies the the superior oblique muscle, and it's contralateral. So the right trochlea nucleus supplies the left superior oblique muscle, and so on. You would have double vision. In all, you would have double vision actually, and you would have weakness in depression of the adducted eye. So if you ask the patient to move his eyes downwards after adducting or medially deviating the eye, he would have exacerbated or worsened double vision. So yeah, again, most importantly, can't see the floor, so can't read a book. The patient would face difficulty going down the stairs. For the abducent, abducent nerve palsy, it supplies the lateral rectus muscle. You would have unopposed action of the medial rectus muscle and medial strabismus or medial deviation, secondary to paralysis of the abductor muscle, the lateral rectus. And this is the image showing you the idea. That's medial strabismus or medial deviation. Okay, so that's the question. A patient presents with acute onset of right eye medial deviation. Okay, so that's right medial strabismus, secondary to what? Think. Right eye medial deviation. It's actually secondary to paralysis of the lateral rectus muscle. Okay, so this is an abducent nerve lesion. Okay, so I can immediately localize the lesion to the pons, because the abducent arises from the pons, okay? And its nucleus lies within the pons also. And spastic paralysis of the left side of the body. Okay, so this is pertaining to the corticospinal tract. The lesion or the clinical deficit will always be contralateral to the lesion, at the brainstem at least. Which of the following is the most likely involved? Okay, so we have the pons medulla, pons medulla. Firstly, is it pons or medulla based on the cranial nerve, the sixth? Yeah, is the pons correct? Now, would it be right medial pons or left, lateral pons? So the abducent nerve and the abducent nucleus, actually, they're both medially placed. But I also know that, the corticospinal fibers are medially placed within the basal pons, okay? And hence the correct answer would be, right medial pons. Because again, remember, the lesion is ipsilateral to the medial strabismus, and it's contralateral to the spastic paralysis. Okay, so that's again medial strabismus, and yeah, that's it for this section. Now we move to the trigeminal nerve. Again, trigeminal, tri meaning three, and geminal meaning born three at a time. You have three principal divisions of the trigeminal: the ophthalmic division or the V1 division, the maxillary division, and the mandibular division. The ophthalmic is purely sensory, the maxillary is purely sensory, and the mandibular is mixed, meaning it's motor to the muscle of mastication and it receives sensations from the lower aspect of the face. Again, origin from the rostral pons connecting to the trigeminal nuclei, including the trigeminal motor nucleus and the three trigeminal nuclei, emerges from the mid pons. The fibers include genosomatic afferent, which is the primary function. Again, it's it relays somatic sensations from the face especially, so pain, temperature, two-point discrimination, vibration, conscious proprioception, and they get processed in the trigeminal nuclei. You have branchial efferents because it supplies the muscles of mastication, which are branchial artery, right? You have SVE, again, this is the same, BE, SVE, SSE, same type of fiber, okay? We have three divisions, V1, ophthalmic, maxillary, and mandibular. V3 is mixed. Now, when it comes to the palsy or damage to the trigeminal nerve, you will have ipsilateral jaw deviation. Why? I want you to think. So we have a right-sided trigeminal nerve, but we have a left-sided trigeminal nerve. They both supply the muscles of mastication on either side. Well, it turns out we have two, muscles that are called the pterygoids, the pterygoid muscles, and they're responsible for sideways movement of the jaw. Okay. When I have a lesion that affects, for example, the right-sided trigeminal nerve, I would have paralysis of the right-sided pterygoid muscles, and I would have ipsilateral deviation of the jaw relative to the lesion. So this way. So if I have right-sided trigeminal lesion, I would have ipsilateral deviation of the jaw, because you have unopposed action of the oppositely placed muscles. They're still functioning well. They're still receiving input from the left trigeminal nerve or the left mandibular nerve. So again, secondary to unopposed action of the oppositely placed pterygoid muscles, this is how it will look like. You will ask the patient to open his mouth, and the jaw would deviate ipsilateral to the lesion or same-sided relative to the lesion. You would have also facial hemianesthesia. If the trigeminal nerve is completely affected, you would have loss of all general sensations from the face, all of it. Okay, of course, ipsilateral. Of course, we have some important reflexes that are linked to the trigeminal nerve. I'll be discussing them later on. But the corneal reflex is important. So we have the cornea. Okay. So the sensations that come from the cornea are transferred through the V1 division or the ophthalmic nerve. Okay, so that's the sensory limb of the reflex. However, the motor limb of the corneal reflex through the facial nerve, because you need to mediate closure of the eyeballs to protect the cornea from irritation. So we test for the corneal reflex through placing a cotton ball on the cornea. Okay, and if we have reflex closure of the eyes, that's a functional corneal reflex, and this is indicative of functional, ophthalmic division and facial. So if you have a lesion that affects the trigeminal nerve, you would have loss of the corneal reflex and the jaw jerk reflex, which we'll discuss later on. Again, it's a lower motor neuron lesion, so you also expect atrophy of the muscles of mastication, similar to element lesions at the level of the spinal cord. And yeah, that's it for this section. We move to the facial nerve, cranial nerve 7. Again, it originates from the caudal pons, think the level of facial colliculus. Remember how the facial nerve loops around the abducent nucleus to arise from the basilar pons, especially the lateral aspect. So again, I reiterate, lateral pontine lesion equals facial motor nuclei involvement or facial nerve involvement, and you would end up with facial paresis, okay, or facial paralysis. Okay, in terms of the palsy or facial nerve lesions, okay, you would have for starters facial paralysis. Okay, so muscle weakness. It makes sense. The facial motor nucleus cannot supply the facial nerve with the branchial efferents it requires to produce facial expression. So you would have an asymmetrical face. That's one. You would also have hyperacusis. Why? The facial also supplies the stapedius muscle, which is a small muscle in the inner ear. It's responsible for dampening the noise, so lowering the noise. Okay, if I have facial nerve lesions or facial nerve damage, I would expect paralysis of the stapedius muscle, and I would have loss of this protective mechanism. So the patient would have sensitivity to loud noise. So he would avoid being in crowds or in malls, for example. He will stay at home, and so on. So that's referred to as hyperacusis. Hyper because it's a lot. Acusis is acu meaning hearing. You would also have a dry eye. Again, just link it to the function. Why would you have a dry eye? Because we have compromised supply to the lacrimal gland. You have decreased tear production, and this will contribute to a dry eye. So again, brachiomotor, you would have facial paresis, hyperacusis. For parasympathetic supply, you would have decreased lacrimation, decreased tear production, a dry eye in effect. You would also have a partially dry mouth due to decreased salivary secretion, because remember, the facial nerve supplies two salivary glands, namely the submandibular and sublingual glands, both. So if you have a facial nerve lesion, you would end up with a dry mouth secondary to decreased salivary secretion by the submandibular sublingual glands. However, remember the parotid is still functional because it receives supply from the glossopharyngeal nerve. So you would have partial dry mouth or a slightly dry mouth. Also remember, in terms of special visceral afferent function or taste function, remember the rostral NTS, the rostral nucleus tractus solitarius, or the gustatory nucleus. It receives taste from the anterior 2/3 of the tongue through the facial nerve. So if I have a lesion that affects the facial nerve peripherally, I would end up with partial loss of taste, especially from the anterior 2/3 of the tongue. The same thing is mentioned in this table. Again, in terms of facial nerve function, facial expression, through the facial motor nucleus at the level of the lower pons, supplies the facial muscles most importantly, and of course the stapedius muscle. This will contribute to facial paralysis and loss of the corneal reflex, because I said the facial nerve is also responsible for reflex eyelid closure through the orbicularis oculi. So if you have a lesion that affects the facial nerve, then the motor limb of the reflex is gone, and hence you would end up with loss of the corneal reflex. It dampens the stapes, meaning it dampens the noise, it lowers the noise. You would have hyperacusis resulting from stapedius dysfunction. In terms of secretion, you would have decreased salivary secretion. And of course, the parasympathetic nucleus of the facial nerve is the superior salivatory nucleus. The parasympathetic nucleus of the glossopharyngeal is the inferior salivatory nucleus. So secondary to a facial nerve lesion, I would expect decreased secretion by both the submandibular sublingual glands and also the lacrimal glands. Because again, the superior salivatory nucleus connects to the pterygopalatine ganglion through the facial nerve and ultimately to the lacrimal gland. However, it connects to the facial nerve and ultimately to the submandibular ganglion and then to the sublingual and submandibular glands. So we have two parasympathetic nuclei associated with the facial nerve, okay, including the two parasympathetic ganglia, the pterygopalatine ganglion and the submandibular ganglion. Finally, we have the taste function. It projects to the rostral or upper solitary nucleus or nucleus tractus solitarius. You have loss of taste in the ipsilateral anterior tongue. Okay, that's it for facial nerve lesions or facial palsy, especially if the peripheral aspect is affected. So when you have a tumor that compresses the pontomedullary junction, the lateralmost aspect of it actually near the cerebellum, you would expect this type of picture. The most important, of course, clinical deficit would be facial paralysis because it's clearly visible. It's clearly evident, okay? And that's it. Let's drink some water. Now we move to, this is a very important section, facial nerve lesions. You need to be able to readily differentiate between upper motor neuron lesions and lower motor neuron lesions of the facial nerve. So actually, we got an SQ about this in the final. So it's a very important concept, but it's relatively simple, inshallah. We'll start with the anatomy. So that's the facial motor nucleus at the level of the pons, if you recall. It has two divisions, or two parts, two portions. We have the upper division of the facial motor nucleus, and we have the lower division of the facial motor nucleus, okay? The upper division, the first fact I want you to know, the upper division or the upper part of the facial motor nucleus is responsible for supplied to the upper muscles of facial expression. So the muscles of the forehead, okay, responsible for frowning, and the orbicularis oculi responsible for closure of the eyeballs, okay? So the upper division is responsible for supply to this portion, okay? So the forehead and the orbicularis oculi is responsible for producing wrinkles. The lower division, on the other hand, is responsible for supplying the lower half of the face. Okay, so think the muscles that are responsible for showing your teeth, for smiling, for blowing, and so on. The lower division of the facial nucleus, again, supplies the lower 2/3 of the face, of the facial musculature. So the important thing that I want to emphasize is that the upper part of the facial motor nucleus receives bilateral cortical supply, similar to the corticospinal tract. When it comes to the spinal cord, in this case, we have an upper motor neuron, the corticonuclear tract, or the corticobulbar tract. The upper division of the facial motor nucleus receives bilateral supply. Okay, this is opposed to the lower division of the facial motor nucleus, which receives unilateral supply from the opposite side. So if you notice, if you go to the right-sided motor cortex, so this is the right-sided primary motor cortex, it sends down fibers, and you have only one cup that supplies the lower division, as opposed to the two cups that supply the upper division of the facial motor nucleus. Okay, so that's the general anatomy. So if I have a lesion that affects one of the cortices, I would expect contralateral, spastic paralysis or facial paralysis of the lower facial muscles, sparing the forehead. So you would have sparing of the forehead. You would have, if you ask the patient to produce wrinkles, you would be able to produce wrinkles bilaterally. However, you would have drooping of the mouth, you would have loss of the nasolabial fold, and so on. So if you look at, I'll start with the lower motor neuron lesion because it's simpler to explain. It's similar to what I discussed here. Again, it's either involving the facial nucleus completely or the facial motor nucleus completely, both the upper and the lower divisions. This leads to ipsilateral facial hemiparesis, meaning the whole face is involved. The whole half of the face is involved because both upper and lower muscles of facial expression are defective. They're both paralyzed. It's an LMN lesion, okay? The forehead is affected in the lower motor neuron lesions, okay? So if you ask the patient to raise his eyebrows, he would only be able to raise his eyebrow on the unaffected side. You would also have the other ideas I mentioned, incomplete eye closure, dry eyes, and corneal ulceration, because also the facial nerve supplies the lacrimal gland, if you recall. So you would have decreased tear production and increased likelihood of corneal damage, because again, you have lubrication of the cornea normally. You have hyperacusis due to superior dysfunction, as we said, and loss of taste sensation from the anterior 2/3 because it carries special visceral afferent and relays it to, the nucleus tractus solitarius. Now, for the upper motor neuron lesion, it's very different. is typically located either within the motor cortex or somewhere between the motor cortex and the lower division of the facial motor nucleus. So you could call the cortical bulbar tract or the cortical nuclear tract above the level of the pons, and you would have an upper motor neural lesion of the facial nerve. Now, the most important thing when it comes to upper motor neural lesions of the facial nerve is that you would have forehead sparing. So you would have contralateral, facial paresis of the lower facial muscles specifically. So the lower facial muscles are affected. However, the forehead is spared. So the patient wouldn't be able to produce, what do you call it? The forehead is spared. So the patient would be able to produce wrinkles actually. Okay, so the wrinkles would look symmetrical. If you look at this image, let's read. Selective weakness of lower facial muscles after cortical bulbar damage. This patient suffered a stroke that resulted in weakness of his left hand. Okay, so that's because of corticospinal involvement, and the left side of the face. So the left lower side of the face, if you notice. Because here we have the nasolabial fold, it's very clear due to muscle tone. We have drooping of the mouth. We have drooping of the mouth. When he tried to bare his teeth, weakness of left lower facial muscles was apparent. However, he could raise his eyebrows symmetrically because, again, you have forehead sparing. What you need to take from this is an upper motor neural lesion will always spare the forehead, okay? It will always spare the forehead. However, a lower motor neural lesion will cause facial hemiparesis, meaning one side of the face is completely paralyzed. So the patient will be able to produce wrinkles on one side. However, it's very difficult to produce wrinkles on the other side. Another point is this is central. This is a central issue. So this is a cortical issue or a cortical bulbar issue, and this is a facial nerve issue. So as it exits the cranium, you can have damage. This could be like a tumor that compresses the facial nerve, and you would have it accompanying symptoms like hyperacusis, loss of taste sensation. Now here only in the upper motor neural lesion, you only have facial muscle paralysis, and that's it. So that's the general idea here. This is a similar picture showing the same aspect. Okay, if the right cortex, the right primary motor cortex is affected, you would have the lesion or the paralysis, the facial paralysis opposite to the lesion. It would be in the lower 2/3 or the lower half of the face. The lower half of the facial musculature is affected because, the lower division of the facial motor nucleus is supplied only once. However, the upper portion or the upper division of the facial motor nucleus is supplied twice. So it still receives supply from, this cortex. Okay, this is central. This is a central issue. As I said, this is a peripheral issue. Again, the peripheral, lesion will result in stuff like decreased lacrimation, so dry eyes, impaired sense of taste, or partial loss of taste due to loss of taste from the anterior 2/3 of the tongue. And that's the idea for facial nerve lesions. Now we proceed to the glossopharyngeal. So for the glossopharyngeal, as the name implies, it supplies a single muscle in the pharynx called the salopharyngeus. The salopharyngeus muscle functions to elevate the pharynx and contract the pharyngeal muscles to allow for swallowing. So if you have a glossopharyngeal nerve lesion, you expect, dysphagia. Actually, it's mild because the major supply to the pharynx is through the vagus. Again, origin is the medulla, lateral to the olives, above the vagus nerve. The fibers, it includes, we have the branchial efferents to supply the salopharyngeus because it's branchial arch derived. We have the GVE fibers, the parasympathetic fibers, which supply, the parotid gland, so it's secretomotor to the parotid gland. We have the general somatic afferents, coming from the posterior 1/3 of the tongue. So again, the glossopharyngeal, as I said previously, is responsible for both taste and general sensations from the posterior 1/3 of the tongue. For the anterior 2/3, you have the facial nerve for taste, and you have the trigeminal for general sensation, the somatic sensations. So again, it's associated with the otic ganglion because it supplies the parotid gland. So the inferior salivatory nucleus is associated with the otic ganglion to ultimately supply the parotid gland. Glossopharyngeal palsy will classically present with dysphagia, difficulty swallowing due to salopharyngeal dysfunction, because the salopharyngeus attaches to pharyngeal muscles, allowing the pharynx to elevate, and open to facilitate the propulsion of food downwards. You would also have anesthesia from the posterior 1/3 of the tongue. Anesthesia simply means complete loss of all sensations, all somatic sensations from the posterior 1/3, because that's the function of the glossopharyngeal, as we said previously. We also have partial loss of taste from the posterior 1/3. Again, it's responsible for both the general and taste sensations, so both special visceral afferent and general somatic afferent. And of course, you would have loss of the gag reflex. This will clue you that, okay, keep in mind that the glossopharyngeal is also sensory to the pharynx. So if I induce gagging, so I place like an object near the posterior pharynx, you would have these sensations traveling through the glossopharyngeal, coming back, and then you have the efferent limb or the motor limb, which is the vagus nerve, to induce a gagging, to eject this foreign substance. And yeah, that's it. So, okay, we have the glossopharyngeal. Again, in terms of functions, elevates the pharynx during swallowing. It's supplied through the nucleus ambiguous. We said that the nucleus ambiguous supplies both the glossopharyngeal and vagus, primarily responsible for supplying the muscles of the pharynx and the larynx. But, you know, the nucleus ambiguous, through the glossopharyngeal at least, only supplies the salopharyngeus muscle. Again, signs include mild dysphagia. You have decreased salivation because, you have damage to the glossopharyngeal and it's responsible for supplying the parotid. The nucleus associated will be the inferior salivatory nucleus. Again, the ganglia, the parasympathetic ganglion will be the auditory ganglion, as we said. It's insignificant because, the submandibular and sublingual glands ultimately cover. When it comes to, taste, again, we have loss of taste from the posterior 1/3 of the tongue. When it comes to general sensations, you have anesthesia from the posterior 1/3 of the tongue. So loss of general sensations, pain, temperature, two-point discrimination, vibration, conscious proprioception, all of them are gone because you have, anesthesia. And of course, this is not really that significant, the last section. And here you have revision of the functions once again. Now we get to the vagus. Again, vagus is Latin for wandering because it's a really large nerve. It accounts for 75% of parasympathetic supply to the body. Again, we're talking about the thoraco-abdominal viscera up to 2/3 of the transverse column. It originates from the medulla, lateral to the olives, below the glossopharyngeal. Fibers include BE, branchial efferents, or branchiomotor fibers, or special visceral efferents, or special somatic efferents. And it's the major nerve that mediates swallowing. Okay. So if I have a vagal nerve lesion, I would expect swallowing defects or dysphagia, difficulty swallowing. It's also the main supply through the nucleus ambiguous. So it gets its branchial efferent fibers or branchiomotor fibers from the nucleus ambiguous from within the medulla. And it ultimately aims to supply the laryngeal muscles and the voice box to produce sound. So talking. So the lesion will present with dysphagia due to paralysis of pharyngeal muscles. You would also have dysarthria or hoarseness due to paralysis of the vocal muscles, so you would have a weak voice. Now, there's another important point. Through the nucleus ambiguous, the vagus supplies 3 muscle groups. We have the soft palate and the uvula, okay, which is, I'll show you an image, inshallah, in the next slide. We also have the pharyngeal muscles that are involved in swallowing, very heavy in swallowing. And we also have the muscles of the pharynx. So if I have a nucleus ambiguous lesion, or a lesion that completely eradicates the vagus nerve, I would expect dysphagia, dysarthria, and deviation of uvula to the opposite side, to the contralateral side. So, and if I'm suspecting a nucleus ambiguous lesion or a vagal lesion, I would expect, I would say, ask the patient to say and I would see the uvula, okay, which is a collection of striatum muscle. It would deviate to the contralateral side. Why? Because let's say you have a right vagal lesion or right nucleus ambiguous lesion. The right side of the uvula would collapse because it hangs in free space, and it would push the uvula towards the opposite side. And hence, when you have a nucleus ambiguous lesion, you would have contralateral deviation of the uvula. This is very important. This will come. And of course, you would have ipsilateral drooping of the soft palate. Again, typically the palate, the palatal tone is maintained through the vagus and the nucleus ambiguous. So if you have unilateral lesions affecting the nucleus ambiguous, one side would droop. One side would fall relative to the other. So again, this is just reiterating everything I said. Now we get to this image. Again, we'll first discuss vagal nuclei, or the nuclei that are associated with the vagus nerve. We have 3 major nuclei that are associated with the vagus nerve. For starters, we have the nucleus tractus solitarius. Okay, the lower part is concerned with the general visceral afferent function. Okay, so think the sensation of gut distension. Think chemoreceptors and baroreceptors from the aorta. The upper part, or the rostral NTS, is concerned with taste. The rostral or upper nucleus tractus solitarius is concerned with taste. Now, for the nucleus ambiguous, which is the most important one, it's responsible for the motor innervation of the pharynx, larynx, and upper esophagus. So So if I have a lesion affecting the nucleus ambiguous, I would expect dysphagia, dysarthria, ipsilateral drooping of the soft palate, as is shown here. So here, if you notice, that's the right side, that's the left side. I have ipsilateral drooping of the soft palate relative to the other side due to probably a lesion to the nucleus ambiguous. And I would have the uvula deviating to the opposite side. Okay, so contralateral deviation of the uvula. Again, so motor innervation of the pharynx larynx, again, through the glossopharyngeal and the vagus. Now, the dorsal motor nucleus is the parasympathetic nucleus of the vagus nerve. It sends the autonomic or the preganglionic parasympathetic fibers to the thoracoabdominal viscera, including the heart, for bradycardia, slowing the heart rate, the lungs for bronchoconstriction, the upper GI for, inducing peristalsis or smooth muscle contraction. So again, in terms of signs, to lesions of the nucleus ambiguous and even the vagus nerve, but most commonly questions the nucleus ambiguous, you have ipsilateral soft palate droop, you have contralateral uvula deviation, as in this case. That's the uvula. Now, this is a question. A patient suffered brainstem stroke. He presents with loss of pain sensations on the right side of the body. So pain sensations from the body, you think what? Spinothalamic tract, so laterally in position probably, okay? And the left side of the face. So this is a function of the spinal trigeminal nucleus. Again, typically, if you have a lesion that affects the spinal trigeminal nucleus, you have ipsilateral loss of face, pain and temperature. Okay, so by this point, I concluded that we have, the spinothalamic tract being involved, especially the left side, because it's contralateral. And we have the left side also here, re-elaborating the point, because the spinal trigeminal nucleus manifests its lesions ipsilaterally. He also presents with flattening of the left side palatal arch. So we have flattening or droop of the palatal arch. So this is probably a left-sided, medullary lesion, because all of these structures are contained within the lateral aspect of the medulla. This includes the left-sided spinothalamic tract. This includes the left-sided spinal trigeminal nucleus. And this also includes the left-sided nucleus ambiguous, okay, responsible for supply to the soft palate, to the left aspect or the left side of the soft palate. Which one of the following parts of the brainstem is involved? So it will definitely be lateral, so just remove medial. Will it be pons or medulla? It would be primarily medulla. So the answer would be left lateral medulla, because again, you have contralateral loss of body pain and temperature, ipsilateral loss of facial pain and temperature, face pain and temperature. You also have ipsilateral flattening of the palatal arch. So yeah, that would be the answer. The answer would be C. Now, finally, the final cranial nerve and its associated lesion, the hypoglossal, again, supplied to intrinsic muscles of the tongue, GSE, general somatic efferent. It arises just lateral to the pyramids, in between the pyramids and the olives. Again, hypoglossal palsy, the tongue would deviate to the same side of the lesion. This is very important. So if you notice here, I asked the patient to open his mouth, and this is the left side, this is the right side. I have left-sided deviation of the tongue. So this simply means that this side of the tongue, or this half of the tongue, is dysfunctional due to a lesion in the hypoglossal nucleus or the hypoglossal nerve. So that's a left-sided hypoglossal nucleus lesion, or a left-sided hypoglossal nerve lesion. So just know by definition, if you have a lesion that affects the hypoglossal nerve or the hypoglossal nucleus, the tongue would deviate to the same side of the lesion, or ipsilaterally. Why? Because these muscles on the opposite side are still functional. So you'd have unopposed, action of the oppositely placed intrinsic tongue muscles pushing it to the side. Element lesion signs, obviously, you'd have atrophy. If you see you have some atrophy compared to the other side, it's thinner in comparison to the opposite side. Again, this is the nature of flower motor neuron lesions. And you would have also muscle fasciculations. But most importantly, you have the tongue deviating ipsilaterally or to the same side of the lesion. And that's it for cranial nerves. That's a very important summary. So this is very important. If you have a lesion that affects the trigeminal nerve, or especially the motor part of the trigeminal nerve, so for example, the trigeminal motor nucleus, you would end up with the jaw deviating towards the side of the lesion. Why? I talked about this previously. You have unopposed action of the oppositely placed muscles. So this will result in, again, ipsilateral deviation of the jaw. For, again, vagal lesions, remember that the vagus supplies the soft palate, the muscle of the pharynx, and the muscle of the larynx through the nucleus ambiguous. You would end up with the uvula deviating away from the side of the lesion. You would have same-sided droop of the soft palate. You would have dysphagia and dysarthria. Again, the reasoning is that the weak side of the uvula that is not supplied appropriately, it collapses and the uvula would point away. For the for the accessory, the accessory is very simple. You'll get a single question about it, and you just need to know the two muscles it supplies. It supplies the sternocleidomastoid and the trapezius. So if I have a right-sided accessory nerve lesion, I will have difficulty turning my head towards the opposite side, so opposite to the lesion. So I would have difficulty turning my head towards the left side. I would also have ipsilateral shoulder drooping, meaning this shoulder would be, lower compared to the other one. And that's it for, again, accessory nerve lesion. For hypoglossal, again, it's an LMN lesion. The tongue would deviate towards the side of the lesion. So lick your wounds. If that helps you, then so be it. Due to weakened tongue muscles on the affected side. Again, this is a reiteration of what I said. Swallowing and vocalization. Again, this is not really that important. Most importantly, it's head and shoulder movements. So sternocleidomastoid and trapezius. Weakness in turning the head towards the opposite side of the lesion and shrugging the shoulder. Hypoglossal ipsilateral deviation of the tongue, most important, upon protrusion. So I would ask the patient to open his mouth and protrude his tongue outwards. That's it for cranial nerves and their most important signs. Now we get to cranial nerve reflexes. This is important. You need to know the afferent/sensory and the efferent/motor limbs of each of the following reflexes, because it can get you a question where you have loss of the accommodation reflex. What possible cranial nerves are affected, and so on. So I'll start with the accommodation. Again, I explained this previously. Accommodation is where you want to refocus your gaze at a closely placed object. Of course, the afferent limb is through the optic nerve, because you need to see that you're looking at a closely placed object. And the efferent limb would be through the oculomotor nerve, because again, it mediates contraction of the ciliary muscle, if you recall, through the ciliary ganglion, and this makes the lens more convex, allowing you to refocus your gaze at a closely placed object. For the corneal reflex, I discussed it briefly before when I discussed the facial nerve. Again, sensory to the cornea would be the ophthalmic, the V1, the first division of the trigeminal nerve. Once I irritate one cornea, I would have reflex, closure of both eyes. I would have reflex closure of both eyes through the facial nerve. Remember, the facial nerve supplies the orbicularis oculi. Orbicularis meaning surrounding the eye. Oculi referring to the eye. You would have bilateral closure in a healthy individual. For the cough reflex, it's very simple. You remember the carina reflex when you have through the gut into the bronchial tree or the carina near the trachea, you would have reflex propulsion of food. Both the afferent and the efferent limbs are through the vagus nerve. For the gag reflex, this is one of the highest yield ones. The afferent limb would be through the glossopharyngeal nerve, because it's sensitive to the pharynx region. So if I, for example, use a cotton ball to touch the posterior aspect of the pharynx, I would have reflex gagging, as the name implies. Again, the efferent limb would be through the vagus, because it supplies the majority of the pharyngeal muscles. Okay. For the jaw-jerk reflex, it's purely a trigeminal reflex. Both afferent and efferent limbs are through V3 or the mandibular nerve. Again, sensitive to this portion, you would essentially put your thumb here and you would hit this with a hammer, and you would have reflex contraction. Again, so that's the idea. Both afferent and efferent limbs through the third division of the trigeminal nerve, namely the mandibular nerve. Okay. For lacrimation, again, it's tear production, it's reflex tear production. The afferent limb is through V1, because again, V1 handles this whole portion of the face, so the forehead and the eyes, especially in the cornea, most importantly clinically. And the efferent limb would be through the facial nerve, because again, it supplies the lacrimal gland, so you would have stimulation of the lacrimal gland through the facial nerve, which contributes to increased tear production, and this is a protective mechanism. This reduces the probability of developing ulceration or damage to the cornea, because you have reflex secretion of tears to protect the cornea. For the pupillary light reflex, it's also very simple. Again, you would shine light onto the patient's pupil, and you would have reflex, pupillary constriction. Okay, so the afferent limb would be through the optic nerve, because you need to see the light, and the efferent limb would be through the oculomotor nerve, because remember, what's the nucleus? I'll ask you this. What's the nucleus that is responsible for pupillary constriction? What is the parasympathetic nucleus responsible for pupillary constriction? That would be the Edinger-Westphal nucleus, or the parasympathetic nucleus of the oculomotor nerve. It provides the GVE fibers to supply the sphincter pupillae and the ciliary muscle, and hence you would have reflex pupillary, constriction. Okay, that's it for cranial nerve reflexes. Okay, so now we're proceeding to talk about the blood supply of the brainstem. This is very important for lesions. This table essentially summarizes all you need to know about brainstem blood supply. This is just, an image to make things more clear. So we can divide the brainstem into two major parts, the medial aspect and the lateral aspect. So medial brainstem and lateral brainstem. For the midbrain, the posterior cerebral artery supplies the entirety of the midbrain, including both medial and lateral parts. For the pons, the medial aspect is supplied through the basilar artery, which is this large artery, which makes sense. It sits within the basilar groove or the basilar sulcus and supplies the ventromedial aspect of the pons. The lateral aspect of the pons is supplied through ICA. So, in other words, what is the significance of this? If I have occlusion of the basilar artery, I would expect the medial pons to be affected. If I have occlusion of ICA, which is anterior inferior cerebellar artery, I would expect lateral, pontine syndromes or lateral pontine lesions. For the medulla, the medial aspect of the medulla is supplied through the anterior spinal artery, and the lateral aspect of the medulla is supplied through pica, which is the posterior inferior cerebellar artery. If you look at the diagram here beneath, we're only concerned with the blue part. The upper part you'll discuss in details when it comes to cerebrum, cerebral blood supply, and ACA, MCA, and whatnot. Here, inferiorly, you see two arteries referred to as the vertebral arteries. They course through the transverse cervical foramina, and they, produce the anterior spinal artery. The anterior spinal artery is a midline structure, if you recall from the start of the session, that sits within the anterior medial fissure between the two pyramids, and it provides blood supply to, again, the medial medulla. For pica, it provides blood supply to the lateral medulla. As we said, again, it's a branch of the vertebral artery. It actually curls like laterally to supply the lateral medulla and also a portion of the inferior cerebellum, but that's not really important for you. The basilar artery supplies the medial and ventral aspect of the pons. Okay, so it sits within the basilar groove, gives off pontine branches, things apply to the medial pons. Now, for the final thing, it would be ICA. Okay, the anterior inferior cerebellar artery supplies the lateral pons. It's a branch of the basilar artery near the junction of the vertebral and the basilar arteries, and it supplies the lateral pons. Okay. And that's it for the blood supply. Just memorize this. And for midbrain, for both any type of midbrain syndrome, the answer will always be posterior cerebral artery, regardless of which branch it's caused by. Okay. Obviously, you have sub branches of the posterior cerebral artery, but for you, all you need to know, if it's a midbrain lesion where you have oculomotor or trochlear nerve involvement, you think about the posterior cerebral artery. Okay. Now, in terms of blood supply, this is another image that makes it very clear. I included two sections, the medulla and the pons. So this is the rostral medulla, and this is the pons at the level of the facial colliculus. So the anterior spinal artery supplies the medial aspect of the medulla. We have four major important structures associated with the medial medulla. We have the pyramids, which correspond to the corticospinal tract. So if I damage the structure, I would expect contralateral spastic hemiparesis. We have the medial meniscus, which carries the sensations of two-point discrimination with vibration and conscious proprioception from the contralateral body. And I have the MLF here very close to the dorsal aspect of the medulla. You would have upper beat nystagmus, again, because the MLF, if you remember, is responsible for coordinating head and eye movement. So nystagmus is essentially where the eye vibrates involuntarily. So it keeps on moving about. The most important, in my opinion, would be the hypoglossal nucleus, because it's the distinguishing feature of strokes that involve the anterior spinal artery. So if you have occlusion to the anterior spinal artery, you have lots of blood supply to this whole strip of tissue, and you would end up with medial medullary syndrome. So ischemia to the medial medulla equals medial medullary syndrome. Ischemia to the lateral medulla, which is this bluish portion, would be lateral medullary syndrome through occlusion of pica. So here, all the structures are included for your convenience. Again, we have hypoglossal nucleus in the medial medulla. For the lateral medulla, we have the inferior cerebellar peduncle, the spinal trigeminal nucleus, the vestibular nuclei, which precipitate vertigo, dizziness. You also have, the nucleus ambiguus. So the nucleus ambiguus is the most important nucleus in the lateral medulla. You'll use it to know it's lateral medullary syndrome because it will always come with dysphagia and dysarthria, always. You also have descending sympathetic fibers. That's for the medulla. I'll discuss it more in the following sections. For the pons, again, it's divided into the basilar part and the tegmental part. For the ventral aspect of the pons, you see bundles of descending corticospinal and corticobulbar, fibers. If you damage the pons unilaterally from the basal parts to the ventralmost aspect, you would expect contralateral spastic paralysis. Same thing. You would notice the pons through the transverse, striated appearance, because you have, the transverse pontine fibers going to the middle cerebellar peduncle. Also, the middle cerebellar peduncle is very large. Again, black equals composed of myelinated nerve fibers or axons, and hence, it's the pons. The medial pons is supplied through the basal artery, especially the ventral part, and the lateral pons is supplied through ICA, which is the anterior inferior cerebellar artery. So if I have an ICA stroke, typically it will present with, same signs as lateral medullary syndrome, but with facial motor nucleus involvement. So I would have facial hemiparesis. So this is, what do you call it? Where's the facial motor nucleus? That's the facial motor nucleus. So if I have lateral pontine syndrome secondary to ICA occlusion or occlusion of the anterior inferior cerebellar artery, I would expect a loss of function of the facial motor nucleus, and I would have signs like, decreased salivation or dry mouth, dry eye, ipsilateral facial hemiparesis, including the whole face, including the forehead, because again, it's a low motor neuron lesion involving the facial nucleus, and other components, of course, which we'll discuss in much more detail. And yeah, now this is very important. This is the rule of fours. Okay, we have four major structures that sit within the medial aspect of the brainstem generally. So when you approach a brainstem lesion question, you can use this rule to identify whether the lesion is medial or lateral in position, and then you look at the cranial nerves involved. For example, if the oculomotor is involved, you think midbrain because it's situated superiorly, and so on. So you have 4M structures, medial brainstem, structures, 4M structures. One would be the corticospinal tract, which is the motor pathway, the primary motor pathway, the descending motor pathway. Secondly, you would have the motor cranial nerve nuclei 3, 4, 6, and 12. So the third would be, the oculomotor, the motor nucleus of the oculomotor nerve. You would have also the trochlear nucleus, the abducens nucleus, and the hypoglossal nucleus. So you can essentially tell where the lesion is based on the nuclei that are involved. If I have the hypoglossal nucleus being affected, then I would immediately localize the lesion to the medulla. Immediately. It's very medial in position. Again, the somatomotor column or the somatomotor nuclei, the nuclei that provide the GSE fibers, are dead center. They are very close to the midline. Another medial structure would be the medial lemniscus, which corresponds to the dorsal column medial lemniscal tract. You would have contralateral loss of, two-point discrimination, vibration, and conscious proprioception. Again, it sits in the middle, dead center. The fourth structure, the fourth M structure, which is medially placed, is the medial longitudinal fasciculus, which will precipitate nystagmus, which will cause nystagmus, which I explained previously. So when it comes to the medial brainstem, we have 4 M structures. We have the motor pathways, namely the corticospinal tract. We have the motor cranial nerve nuclei, including the oculomotor, the trochlea, the abducens nuclei, and also the hypoglossal nucleus. We have the medial lemniscus, which corresponds to the dorsal column medial lemniscal tract. And we have the MLF, the medial longitudinal fasciculus. You can use this to localize the lesion to either medial brainstem or lateral brainstem. For a lateral brainstem lesion, you have 4 side structures, so lateral side, 4 side structures that are affected. They start all with S. We have the spinothalamic tract, or the spinothalamic pathway, which carries pain and temperature from the contralateral body. We have the spinocerebellar pathway, or just cerebellar pathway. So this could be a peduncle, this could be a spinocerebellar tract, whatever. Okay, so this will precipitate ipsilateral, same-sided ataxia. You have descending sympathetic pathways. So S, again, side lesions or side structures. Now, this is a very important point. At the level of the brainstem, you have some descending sympathetic fibers that ultimately supply the preganglionic sympathetic fibers going to the facial region. So if I have a lesion that affects the descending sympathetic pathways, I would expect ipsilateral Horner syndrome, because you have loss of sympathetic flow to the ipsilateral face, or the same side of face, relative to the lesion. So the clinical features will include ptosis, meiosis, and anhydrosis. Why would you have meiosis? Due to unopposed pupillary constriction through the parasympathetic fibers of the oculomotor nerve. And finally, the fourth S structure, or the fourth side structure, would be the spinal trigeminal nucleus, or the accessory nucleus of the fifth nerve. Again, think ipsilateral, pain and temperature from the face. Okay, so 4 M structures. Motor pathway, meaning corticospinal. Motor cranial nerve nuclei, 3rd, 4th, 6th, and 12th. Medial lemniscus, meaning, of course, what do you call it? Dorsal column medial lemniscal tract, and medial longitudinal fasciculus, 4 M structures in the midline. For side structures, spinothalamic pathway, spinocerebellar pathway, descending sympathetic fibers, and finally, the spinal trigeminal nucleus, which again carries or relays, pain and temperature from the ipsilateral face. That's it. You can, after knowing whether it's medial or lateral, okay, you can look at the cranial nerve that are involved. For example, if the facial nerve is involved, you would know it's the lateral pons. Okay, the pons, because the facial motor nucleus exists within the pons. Same applies for other lesions. If you have a lesion that affects, the nucleus ambiguous, for example, you know that the nucleus ambiguous sits laterally within the medulla, and hence it would be, localized to the medulla, and so on. Okay, so we start with the first very important syndrome. Medullary syndromes are the most important, in my opinion. You have medial medullary syndrome. It occurs secondary to occlusion of the anterior spinal artery. So if you have occlusion of the anterior spinal artery, this would lead to ischemia of the medial medulla. So most ventral structure that is affected would be the pyramidal tract, so descending corticospinal tracts or fibers. You would have contralateral spastic hemiparesis or hemiplegia. Now, what is hemiparesis? Hemiparesis is muscle weakness. It's spasticity, but you're still able to move the muscle. You're still able to move your body part. This is opposed to plegia or hemiplegia. You have complete paralysis, complete loss of function. So, because you have ischemia involving the pyramid or the corticospinal tract above the decussation, you would have contralateral spastic hemiparesis. Because the medial lemniscus is involved, you would have contralateral loss of 2-point discrimination, vibration, and conscious proprioception. Because the MLF is involved, you would have upbeat nystagmus, meaning involuntary movements of the eye up and down, because the MLF, I talked about its function, coordinates head and eye movement. And finally, the distinguishing feature, this is very important, the defining feature that you will use to distinguish medial medullary syndrome from other syndromes in questions is the hypoglossal nucleus. If the hypoglossal nucleus is involved, you would have ipsilateral deviation of the tongue, okay? So ipsilateral tongue deviation, this will always tell you it's medial medullary syndrome because it's very dorsal in position. It's very close to the 4th ventricle. So that's it for medial medullary syndrome, okay? Again, the 4 major structures that involve ventral to dorsal, pyramids, medial lemniscus, MLF, medial longitudinal fasciculus, and the hypoglossal nucleus, which is GSE, motor supply to the intrinsic tongue muscles. You would have ipsilateral tongue deviation secondary to unopposed action of the oppositely placed functional muscles. And that's it for medial medullary syndrome. Now we proceed to lateral medullary syndrome or Wallenberg syndrome. And yes, you need to know the name because you can, say Wallenberg syndrome in the question and you wouldn't know it's lateral medullary. It's very similar. You just have other structures you need to know about. It typically results from occlusion of pica, the posterior inferior cerebellar artery, which supplies this portion, this blue portion, the lateral medulla. The key structures that are involved include 6 structures, but the distinguishing feature that I want you to remember the most is the nucleus ambiguous, which sits within the lateral medulla. This is the nucleus ambiguous. In terms of function, it's motor to the muscles of the pharynx and the larynx. So you'd expect if the nucleus ambiguous is damaged, or you would have pica occlusion, you would have dysphagia or difficulty swallowing, and dysarthria or hoarseness, weak sound, because you have paralysis of the pharyngeal muscles and paralysis of the vocal muscles. So that's the distinguishing feature. That's the first structure that is affected. Secondly, you have the vestibular nuclei, which are very lateral in position. If they're affected, you would end up with vertigo, dizziness, because again, they play a part in equilibrium and balance. I can just know that the vestibular nuclei and the vestibulocochlear nuclei, they sit very lateral in position at the pontomedullary junction. So if you have pica occlusion, the vestibular nuclei would be affected. You would have some, vestibular signs like vertigo, dizziness, like nausea, like vomiting. They're all an extension of vestibular nuclear damage. Now we also have the side structures. If you recall, we have the spinothalamic pathway. So you have contralateral loss of body pain and temperature. That's the spinothalamic tract. Okay. You also have another side structure, the spinal trigeminal nucleus, okay, which is responsible for ipsilateral pain and temperature from the face. So you have ipsilateral loss of pain and temperature from the face. Also, because the inferior cerebellar peduncle is involved, or even the spinocerebellar tracts are involved, you would end up with ipsilateral same-sided ataxia and dysmetria. Again, ataxia is, weird, jerky muscle coordination, and dysmetria is overshooting or undershooting, as I explained previously. And finally, you would have, again, descending sympathetic fibers, these dots, small dots, that are going to excite the preganglionic sympathetic fibers to the face. So you'd have ipsilateral Horner syndrome, ptosis, meiosis, and hydrosis. And it would be partial ptosis and not complete, because in oculomotor palsy, you would have complete ptosis because the LPS is completely paralyzed. However, in Horner syndrome, you'd have partial ptosis. And of course, the major sign that will help you is meiosis, which is unopposed pupillary constriction, because the sympathetics are completely gone. So you need to know these structures, but most importantly, if you see the nucleus ambiguous being affected, you think, of course, dysphagia and dysarthria. There's a nice mnemonic you could remember. It's pica-chew, pica occlusion, chew, inability to chew. So pica occlusion will result in the inability to chew, i.e. dysphagia, secondary to damage to the nucleus ambiguous, so pica-chew. Yeah, that's it for lateral medullary syndrome. Again, there are very different manifestations. What you need to focus on in terms of medial medullary syndrome would be the hypoglossal nucleus. In terms of lateral medullary syndrome, it would be, the nucleus ambiguous. And they can ask you this in an SQ. List the structures that are involved in lateral medullary syndrome, for example. Okay, medullary syndrome summary. This is the same thing. I just reiterated this. You see, most importantly for pica occlusion or lateral medullary syndromes, nucleus ambiguous, dysphagia, hoarseness, and loss of the gag reflex, because you have loss of the motor limb of the gag reflex through the vagus nerve, which is responsible for producing the gag. Again, lateral medullary syndrome, Wallenberg syndrome, the nucleus ambiguous effects are specific to pica lesions. That's what I'm reiterating. If you have dysphagia and dysarthria, this is specific to a pica lesion or a pica occlusion. Same thing, same structures I mentioned, vestibular nuclei, side structures, and the inferior cerebellar peduncle producing ipsilateral ataxia and dysmetria. Anterior spinal artery occlusion, medial medullary syndrome, you think primarily corticospinal, medial meniscus, and hypoglossal nucleus. And that is it. Okay, now we move to the pontine syndromes, okay? They're not that difficult, and the doctor doesn't ask much about them. But the first would be the Miller-Gubler syndrome, or the ventral pontine syndrome. As the name implies, the basis pontis is involved. The ventrocaudal aspect is involved. So the basilar part of the pons is involved at a lower section, at the level of the facial colliculus. So if you see here, that's the facial colliculus. This whole section goes ischemic. So what are the three structures that are included here? For starters, you have the corticospinal tract. So you'd have contralateral spastic hemiparesis. That's one. Secondly, you see the fascicles of the 6th and the 7th cranial nerve. So that's the 6th cranial nerve. Okay, that's the 7th cranial nerve. So the abducent and the facial. So both are involved. If the abducent nerve is involved, you would have medial strabismus due to unopposed action of the medial rectus muscle, because again, the abducent nerve supplies the lateral rectus muscle responsible for eye abduction. And hence you would end up with ipsilateral medial strabismus for affecting the abducent fascicle. For affecting the facial nerve itself, you would have a lower motor neuron lesion of the facial nerve, as we described previously. But most importantly, you would have ipsilateral facial hemiparesis. You would have other signs like, potentially dry mouth due to loss of parasympathetic supply to the submandibular and sublingual glands. You would also have like a dry eye secondary to decreased lacrimation, because the facial nerve supplies the lacrimal gland. You also have loss of taste, partial loss of taste from the anterior 2/3 of the tongue, because the facial nerve is responsible for this function. And that's it for ventral pontine or Miller-Gubler syndrome. Again, lower section, basal pons, unilateral involvement, lower section. For Raynaud's syndrome, it's relatively identical to, the Miller-Gubler syndrome. However, you have no facial nerve involvement because it's ventromedial. So the facial nerve lies lateral usually. So the facial nerve fascicle arises from the lateral pons, and even the facial motor nucleus lies within the lateral pons. So you would only see facial motor nuclei involvement in an ICA lesion, ICA occlusion, if you recall. So again, nature is a lesion of the ventromedial pons. So ventral aspect of the basilar part of the pons, and it's very medial. We have two structures that are involved. We have the corticospinal tract, so contralateral spastic hemiparesis, and of course the fascicle of the abducent nerve is involved. So you'd have unopposed action of the medial rectus and medial strabismus, ipsilateral medial strabismus. So again, pyramidal tract, contralateral hemiplegia. The abducent fascicle is involved. Again, here you wouldn't have facial nerve involvement because it's very medial in position, as opposed to Miller-Gubler syndrome, where you have the facial fascicle also involved. Okay. Now we proceed to locked-in syndrome. Now, this always comes in exams. The doctor will always bring it to you in the context of, again, as I said, I reiterate, an alcoholic patient, with hyponatremia, so low presence of sodium in the blood, and you correct for the hyponatremia too quickly. So you have a rapid rise in plasma osmolarity, and this leads to demyelination of the basilar pons bilaterally. So you have, it's a lesion of the basilar pons bilaterally due to demyelination, sorry. So that's the basilar pons, okay? You have complete demyelination of the basilar pons. So you have bilateral involvement of the corticospinal tract, producing quadriplegia. For locked-in syndrome, the case will always be a patient presents to the clinic with hyponatremia, the physician corrects it too quickly, and you end up with quadriplegia. If you just know that quadriplegia relates to locked-in syndrome, that's all I need. Okay, that's all I need. Because again, you have bilateral involvement of the corticospinal fibers. Of course, the corticobulbar tract is also involved, the corticonuclear tract, which is descending through the basilar pons. It's also a lesion, so you end up with loss of all motor function in the head and neck region. The patient will only be able to move his eyes vertically. That's it, nothing else. And that is the reason for the name locked-in syndrome. Interestingly, patients communicate with doctors through, having an algorithm. So, for example, moving the eye upwards would translate to yes, moving the eyes downwards would correspond to no, and so on. So just know, secondary to rapid correction of hyponatremia, bilateral basilar pon lesion, meaning both aspects are affected. That's the reason. And you would have loss of all motor function. And that's an MRI. You see the cerebrum, the corpus callosum, whatnot. You see the pons. That's the pons. That's the medulla. That's the pons. That's the cerebellum. That's the fourth ventricle. The basilar pons is completely demyelinated. This is referred to as either osmotic demyelination or central pontine myelinolysis. Okay. This can also happen in complete basilar artery occlusion. So the basilar artery gets completely occluded, and you have complete, loss of blood supply to the ventral pons. This can also happen, but usually in questions is too rapid correction of hyponatremia. Yeah, that's it for locked-in syndrome. Pontine syndrome summary, again, basilar artery, think corticospinal, bulbar tracts. Again, if it's completely occluded, you have bilateral involvement, so you'd have quadriplegia. You would also have loss of all head and neck motor function. You cannot move the mouth, you cannot move the tongue. You only maintain vertical gaze. Okay. Again, a mnemonic for this would be locked in syndrome, locked in the basement, because the basilar artery is occluded, meaning base, if you get me. And that's the idea for, again, either locked-in syndrome in terms of osmotic demyelination or secondary to basilar artery occlusion. This is very important. ICAS strokes. ICAS strokes correspond to lateral pontine syndromes. Now, it's not explicitly mentioned in your slides, but the doctor actually asked about it. So ICAS applies all structures in the lateral pons, which correspond, they're identical to structures within the lateral medulla, by the way, except for a single structure that is specific to ICA occlusion or lateral pontine syndrome. It's the facial motor nucleus, okay? So you would have the facial motor nucleus being completely damaged, and this will lead to, ipsilateral facial hemiparesis involving the entire half of the face. Okay, you would have decreased lacrimation because you have decreased lacrimal secretion, decreased salivation due to loss of parasympathetic supply to the submandibular sublingual glands, decreased taste from the anterior 2/3 secondary to loss of facial nerve taste function. And this is very important. Lateral pontine syndrome, facial nerve nuclei effects are specific to ICA lesions. So if you see the facial motor nucleus as being involved, you would think this is a lateral pontine syndrome. Almost always, okay? This is very important. Other structures that are identical to lateral medullary syndrome include, again, the vestibular nuclei, which would cause vomiting, vertigo, nystagmus, because again, they lie at the junction between. So this is the pons, this is the medulla. In between, you have the vestibular cochlear nuclei. So if you have a lower pontine stroke or an upper medullary stroke, in both you would have vertigo, nausea, vomiting, which are vestibular signs. Other side structures that are involved because this is lateral pontine syndrome include the spinothalamic tract and spinal trigeminal nucleus, identical, contralateral loss of body pain and temperature, ipsilateral loss of pain and temperature from the face. You also have descending sympathetic fibers, so you have ipsilateral Horner syndrome. The middle and inferior cerebellar peduncles. Again, remember, any cerebellar involvement will precipitate ipsilateral same-sided ataxia/dysmetria, which are cerebellar signs. That's all you need to know for brainstem. You'll discuss it more in details in cerebellum lecture. If the cochlear nuclei are affected. You could also have sensory neural hearing loss or just deafness on the same side of the lesion. However, he won't really ask you about this. He'll focus on the facial nerve nuclei or the facial motor nuclei, which correspond to a lower motor neuron lesion of the facial nerve. Where you have ipsilateral facial hemiparesis and loss of facial expression, inability to produce wrinkles on the side of the lesion, and so on. That's it for Pontine syndromes. Again, for midbrain syndromes, we have two major syndromes you need to be aware about. We have Weber syndrome. It's also referred to as ventral cranial nerve 3 fascicular syndrome or ventral oculomotor fascicular syndrome. As the name implies, the ventral aspect of the midbrain is involved. So that's the cross cerebri here. You have the substantia nigra and the white matter bundles, which contains descending motor pathways, descending corticospinal, corticonuclear fibers. So the ventral aspect of the midbrain is involved, including the medial aspect of the cerebral peduncle. So remember, lesion of the medial cerebral peduncle or the cross cerebri will damage two structures. You have the pyramidal tract or the corticospinal tract. You would have contralateral spastic hemiplegia or hemiparesis, and the fascicle of the oculomotor nerve is also involved. So you'd end up with ipsilateral oculomotor palsy. I'll ask the student who's attending this and revising. So what are the clinical features that tell you it is oculomotor palsy, or it's a lesion that affects the oculomotor nerve? Yeah, the eye would deviate down and out. So lateral strabismus, also complete ptosis, and mydriasis due to unopposed pupillary dilation, because the oculomotor nerve supplies the sphincter pupillae muscle, which mediates pupillary constriction. Again, this is another image, same thing. The fascicle of the oculomotor nerve is lesion. The medial aspect of the cross cerebri is also involved. So the descending corticospinal fibers, are damaged. You have contralateral hemiplegia. Okay, this is the same thing. Midbrain stroke due to occlusion of, again, posterior cerebral artery. Just forget about this part. If it's a midbrain lesion, if you're sure it's a midbrain lesion, just connect it immediately to posterior cerebral artery, because both lateral and medial aspects are supplied through the posterior cerebral artery. You would have same-sided or ipsilateral oculomotor palsy and contralateral hemiplegia. And that's it for Weber syndrome. For Benedict syndrome, it's dorsal cranial nerve 3 fascicular syndrome or dorsal oculomotor fascicular syndrome. So the oculomotor fascicle is involved. So you'd also have oculomotor palsy here. However, it's more dorsal in position. So it's within the tegmentum. This would be the cross cerebri, and this would be the tegmentum. So the red nucleus is involved. I mentioned this previously. If you have a lesion that involves the red nucleus, what is the clinical deficit or the functional deficit that will result from this lesion? Think. You would have contralateral tremors, contralateral involuntary movements, because the red nucleus is typically involved in regulating voluntary movement on the opposite side, and hence the two structures you need to recall. Again, this is dorsal, more dorsal in position, so the cross cerebri is not really involved as opposed to Weber syndrome. The red nucleus is lesion. You would have contralateral involuntary movements, tremors, hemichorea. Again, chorea is Latin for dance. We'll take this in more detail in the basal ganglia lecture. You would have oculomotor palsy, a blown pupil, so adipose pupillary dilation, and it would be deviated down and out, so down and out gaze. And that's it for this part. Again, this is ipsilateral, this is contralateral, and that's for Benedict syndrome. Thank you very much for attending this session. If you have any questions, please reach out, send an email, or send me a message on WhatsApp, and I'll be very obliged to help you, inshallah. Good luck in your exams, and thank you for watching this. For feedback, please scan this QR code, and لا تنسوا تصلوا على النبي. السلام عليكم.